just need to get your views from up here. Everywhere I go, people ask me about it. And I know lung cancer is spectacular.
Serena has been for 2 years. That's why she's on the final MEDCAC.
No, so if we have another one this year, I think that will be her final.
So I've been 4 years. And I figured that's probably because second time and
Right,
and then you have to take a pause or something.
Right. And then
I'll shoot him a quick email and say you're here.
trying to wait for Rita. She went to the restaurant, but I wait for that. You're gonna win the lotto before that happens. Which is my retirement.
I won't say
No. I now have no retirement.
I have to tell you.
I'll sit it down there, Jamie. So I have collected a bunch of material from.
I used to read every page. Right. Now that I'm having
No, they put it on.
I'll see this.
Oh, I did that. From Lung Cancer Alliance? Yeah. Why?
I just can't
Because they wanted to get them together.
I don't know why we need this because this is dangerous now.
You have to put it in it. See, it says you actually have to enter it in the network. Well, that's the question. Yeah, I had a question.
Speakers list.
Yeah, I tried the CMS guest. I tried the. Oh, I tried it. No, I tried the long one.
Easy going type of rate, not like shutting off people like the other ones. Kidding. It's got like very sharp, but it's also kind of sometimes not encouraging much conversation.
I made a mistake, but
It's good to give like leadership an opportunity one by one for people to speak up respectfully. I think that he was great. Honestly, I learned quite a bit from him. Rita has been fantastic. If I were to end up ever in my future life being the chair, I would probably combination of the two. And Barbara. I remember Barbara. Yeah, Barbara was great too.
This is my
Fourth cycle.
how do you want me to Tamara search?
Yeah.
You want a cup of water? I got it. Oh my God. This is heavier than hell.
Good morning. We're about to start the meeting. Good morning and welcome, committee chairperson, vice chairperson, members, and guests. I am Maria Ellis, the Executive Secretary for the Medicare Evidence Development and Coverage Advisory Committee, MEDCAC. The committee is here today to discuss the use of low-dose computed tomography, LDCT screening for lung cancer in adult smokers. The following announcement addresses conflict of interest issues associated with this meeting and is made part of the record. The conflict of interest statutes prohibit special government employees from participating in matters that could affect their or their employer's financial interests. Each member will be asked to disclose any financial conflicts of interest during their introduction. We ask, in the interest of fairness, that all persons making statements or presentations disclose if you or any member of your immediate family owns stock or have another formal financial interest in any company, including an internet or e-commerce organizations that develops, manufactures, distributes, and or markets consulting, evidence reviews or analysis, or other services related to LDCT screening for lung cancer. This includes direct financial investments, consulting fees, and significant institutional support. If you haven't already received a disclosure statement, they are available on the table outside of this room. We ask that all presenters please adhere to their time limits. We have numerous presenters to hear from today and a very tight agenda, and therefore cannot allow extra time. There is a timer at the podium that you should follow. The light will begin flashing when there are 2 minutes remaining and then turn red when your time is up. Please note that there is a chair for the next speaker, and please proceed to that chair when it is your turn. We ask that all speakers addressing the panel please speak directly into the mic and state your name. For the record, voting members present for today's meeting are Dr. Art Sadrakian, Dr. Harry Burke, Dr. A. Mark Fendrick, Dr. Mark Grant, Dr. Joe Carroll Hyatt, Dr. David Howard, Gail Malkus, Dr. Gail Malkus, Dr. Curtis Mock, and Dr. Gerald White, Jr. A quorum is present and no one has been recused because of conflicts of interest. The entire panel, including non-voting members, will participate in the voting. The voting results will be available on our website following the meeting. I ask that all panel members please speak directly into the mics, and you may have to move the mic since we do have to share. This meeting is being webcast via CMS in addition to the transcriptionist. By your attendance, you are giving consent to the use and distribution of your name, likeliness, and voice during this meeting. You are also giving consent to the use and distribution of any personally identifiable information that you or others may disclose during today's meeting. Please do not disclose personal health information. In the spirit of the Federal Advisory Committee Act and the government in the Sunshine Act, we ask that the advisory committee members take care that their conversations about the topic at hand take place in the open forum of the meeting. We are aware that members of the audience, including the media, are anxious to speak with the panel about these proceedings. However, CMS and the committee will refrain from discussing the details of this meeting with the media until its conclusion. Also, the committee is reminded to please refrain from discussing the meeting topic during breaks or lunch. If you require a taxi cab, there are telephone numbers to local cab companies at the desk outside of the auditorium. Please remember to discard your trash in the trash cans located outside of the room. And lastly, all CMS guests attending today's MEDCAC meeting are only permitted in the following areas of CMS single site: the main lobby, the auditorium, the lower level lobby, and the cafeteria. Any persons found in any area other than those mentioned will be asked to leave the conference and will not be allowed back on CMS property again. And now I would like to turn the meeting over to Tamara Sirk Jensen.
Thank you, Maria. I know we have a packed agenda today, so I'm going to keep it very short. I just want to thank everyone for coming to the MEDCAC today. This is an important meeting for us. As many of you know, we have an open national coverage determination going on right now, and this is a part of our information collection to use to make a decision on this particular topic, which will be due in mid-November. So our national coverage determination proposed decision is due in mid-November, where everyone can then have another 30-day public comment on that proposed decision, and then we will issue a final 90 days after the proposed has been made public. And we haven't missed any statutory due dates, so I think you can expect those dates to be met. So look for that decision in that time. So this is a very important meeting to us for this for that decision, and we will be using the information in this meeting to help us make that decision. And this meeting is about the evidence and what this panel thinks of the evidence. And so we're very excited to hear from all of you and our panel. I just want to remind you that I know today's meeting is very, very structured, and Rita and Art are going to have a very hard job of time managing the entire meeting. So please don't be offended if we say you only have 10 seconds. If you have not finished what you need to tell us, please give it to us in writing. We will take it under advisement. But we do need to get the meeting, everybody to have a chance in the meeting, and that is why there are certain time constraints on there. And we do depend on Rita and Art making sure that those time constraints are met today. So again, thank you to all of you for showing up, and a very special thanks to the MEDCAC members for coming here today. And then I'm going to turn it over to Rita Redberg.
Thanks very much, and I just want to add my welcome to Maria and Tamara's, to everyone here as well as the committee, and we really appreciate everyone's service and interest in this important question we have before us today. I think we'll just start out. I'll introduce myself, and then we'll go down the line, and everyone will introduce themselves. I'm Rita Redberg. I'm a professor of medicine at the University of California, San Francisco. I'm also a cardiologist there. I am also the editor of the JAMA Internal Medicine. I have no conflicts of interest. I did write an op-ed in the New York Times in January called "We're Giving Ourselves Cancer," that concerned the excess cancers that are occurring in the U.S. From radiation risks, and we discussed ways to decrease radiation risks and excess cancers in the U.S. I had no knowledge of the MEDCAC meeting, and we were not specifically addressing lung cancer screening, but we did talk about CT scans. Similarly, in the journal I edit, we have a series called Less is More, where we do discuss harms as well as benefits of new technologies, and it's talking specific about how to weigh harms and benefits of those technologies. I'm here on my own behalf and not representing the journal.
I'm Art Sidrakian. I'm an associate professor at Weill Cornell Medical College. I'm directing patient-centered comparative effectiveness research program focusing on devices and surgical interventions. And I don't have any conflicts related to this MEDCAC.
Good morning, Mark Fendrick, general internist. I direct the Center for Value-Based Insurance Design at the University of Michigan. No conflicts.
Harry Burke, Associate Professor, Biomedical Informatics and Medicine, Uniformed Services, University of Health Sciences, and I have no conflicts of interest, and nothing I say represents the federal government.
I'm Mark Grant. I'm the Director of Technology Assessments at the Center for Clinical Effectiveness of Blue Cross Blue Shield Association. Obviously work for an insurer, which does cover Medicare beneficiaries, but I'm here on my own behalf and have no conflicts of interest to disclose.
Good morning. I'm Jo Carol Hyatt. I chair the Interregional New Technology Committee with Kaiser Permanente, and I'm also here on my own behalf with no conflicts, and I'm a general surgeon.
I'm David Howard. I'm a faculty member at the Rollins School of Public Health and Winship Cancer Center of Emory University, and have no conflicts of interest.
Good morning. I'm Gail DeRamo-Malkus, and I'm professor of nursing at the NYU College of Nursing and associate dean for research. I'm also a certified adult nurse practitioner and a fellow in the American Academy of Nursing, and I have no conflicts.
I'm Curtis Mock, certified in family medicine and geriatrics, serving as the National Medical Director for Complex Population Management with Optum Health. I'm here on my own behalf as a patient advocate, and I have no conflicts.
I'm Jerry White. I'm a clinical medical physicist in Colorado Springs, and I have no conflicts.
I'm Martin Marciniak. I'm the Vice President for U.S. Health Outcomes and Medical Policy for GlaxoSmithKline. I'm also the industry rep.
And I'm Paul Dory-Rose. I'm an epidemiologist at the National Cancer Institute, and I'm here on my own behalf today, and I have no conflicts.
Michael Gould. I'm a pulmonologist and a health services researcher. I direct the Program in Health Services Research in the Department of Research and Evaluation at Kaiser Permanente, Southern California. I have written fairly extensively about pulmonary nodule evaluation and lung cancer screening, served as a member of the multi-society task force for lung cancer screening guidelines sponsored by the American College of Chest Physicians and the American Society of Clinical Oncology. And I've received salary support from Archimedes to help develop computer models of lung cancer screening.
I'm Jeff Rich. I'm a practicing cardiac surgeon and chief of cardiac surgery at Centera Healthcare. I do not do thoracic surgery, so I have no conflicts with regard to any decision made here. I'm a past president of the Society of Thoracic Surgeons, but don't have a leadership role in that society anymore, but I have been very sensitive to these issues for the membership of our society, and I'm here representing myself.
Steve Wolf, professor of family medicine and population health at Virginia Commonwealth University. No conflicts of interest to report. I do have a long history with the U.S. Preventive Services Task Force, 16 years, both as a staff member, later as a member of the task force, and ultimately a senior advisor to the task force. But this was many years ago when the primary screening test was chest x-rays, and have not been involved with the task force for about 10 years and was not involved with the current recommendation that we're deliberating
on. Okay, thank you all. And with that, I would like to introduce our first speaker, Dr. Joseph Chin, who will present the CMS presentation as well as the voting questions.
Good morning, I'm Joseph Chen. I'm in the coverage analysis group. I'm the lead medical officer for this topic today, screening for lung cancer with low dose computed tomography in adult smokers. I will be presenting some basic background about lung cancer screening and also about how Medicare considers preventive services statutorily is different than evaluation and management services. I'll also read the voting questions for the record. Cancer for the lung and bronchus is third most common category of cancer, as estimated in 2013 by the National Cancer Institute. This is from their website, the SEER data. In 2013, there was over 200,000 new cases estimated and accounting for 159,000 deaths. The NCI recently, sort of posted estimates for 2014. The numbers and relative rankings are consistent with the 2013 numbers. New cases of lung cancer and bronchus cancer. The majority of new cases, as you can see from the graph here, occurs in older adults, 65 years old and older, accounting for over 68% of the new cases. Median age of diagnosis at 70 years. And again, the 2014 estimates from NCI were similar. Deaths from lung cancer also occurred largely in adults over 65 years of age. Basically, this category accounts for about 70% of all deaths in the older age group. The median age at death, 72 years. So with the new number of new estimated cases and also the estimated deaths, there is a disproportionate share in older adults, essentially the Medicare population. Also another slide from the NCI SEER website, which looks at stage diagnosis and survival. And unfortunately for lung cancer, most of the cases are diagnosed at a pretty late stage with distant metastases, which is associated with a relatively poor 5-year survival rate. So in that sense, if there were a suitable screening test to diagnose, to early detect this condition, for example, in the localized stage, there is some possibility for improving the 5-year relative survival. The number of risk factors for lung cancer, also again from the NCI website, we'll be focusing on the first one, smoking cessation, cigarette smoking and tobacco use, now and in the past. These other ones are important, however, we won't be discussing them today. We can get a sense of smoking status in the Medicare population by looking at the Medicare Current Beneficiary Survey, which is a long-standing representative survey of the Medicare population. In 2011, 14% of respondents were current smokers, and 44 were former smokers. This pattern has basically been pretty consistent over the years, and this figure at the bottom here shows over the past 10 years, and there's been a little change in least reported smoking status in the Medicare population. Unfortunately, in the current survey, there is no question about smoking history or cumulative smoking risk. So, lung cancer screening has actually been a consideration for many years, dating back to the 1960s and 70s. Actually, as Dr. Wolf mentioned, in that time period, it was really started off with sputum cytology and chest X-ray, or a combination, and none of those approaches really panned out. Screening studies with low dose CT actually gained attention probably in the late 90s. And even the early studies on LDCT screening did not conclusively show mortality benefits until 2011, when the results of the National Lung Screening Trial were published, which actually showed that screening with 3 annual low-dose CTs reduced mortality from lung cancer compared to chest X-rays in adults 55 to 74 years of age who had at least 30 pack year history. And this is the publication that came out in 2011. The next few slides will go over basically how CMS Medicare considers preventive services. Historically, Medicare was established in 1965. To pay for items or services that are reasonable and necessary for the diagnosis or treatment of illness or injury, or to improve the functioning of a malformed body member. So this basic language has generally excluded preventive services. Medicare does cover a number of preventive services. Starting back in 1997 with the Balanced Budget Act. In 2008, CMS did receive authority through the Secretary of HHS to add additional preventive services in the Medicare Improvements for Patients and Providers Act. We refer to it as MIPA. Section 101, improvements to coverage of preventive services, which lays out the criteria that CMS considers to add additional preventive services. All these criteria need to be met. Reasonable and necessary for prevention or early detection of illness or disability, recommended with a grade A or grade B by the U.S. Preventive Services Task Force, and appropriate for individuals entitled to benefits under Medicare Part A or enrolled under Medicare Part B. So the U.S. PSTF recommendations are important to our considerations. It's one of the 3 criteria. I mean, it's necessary, it's not sufficient by itself. For those that may not be familiar, the USPSTF is an independent panel of non-federal experts in prevention and evidence-based medicine, and conducts scientific evidence reviews of a broad range of clinical preventive health care services such as screening, counseling, and preventive medications, and develops recommendations for primary care clinicians and health systems. That's taken directly from their website. The Agency for Healthcare Research and Quality, AHRQ, AHRQ, provides the administrative and operational support to the task force. So the task force has looked at lung cancer screening several times, and their first recommendation in 1985 was a D. So their course of recommendations have paralleled the sort of the developments in the evidence. In 2004, the recommendation was changed to an I, and at the end of last year, 2013, the USPSTF revised their recommendation to a grade B here for annual screening for lung cancer with low-dose computed tomography in adults aged 55 to 80 years who have a 30-pack year history and currently smoke or have quit within past 15 years. This is a fairly complex recommendation. There's a number of considerations to look at, especially for implementation. For example, accurately ascertaining smoking history, which is most commonly self-reported. That's really a factor that may influence the risks and benefits actually in a screening program outside of specific clinical controlled trials. The NLST investigators also noted a number of implication issues in their publication. They basically focused on the expertise in radiology and in the diagnosis and treatment of cancer in their in participating medical centers of the trial, which may or may not actually, as they mentioned here, be available in some community facilities. So on to the voting questions. Voting question 1, how confident are you that there is adequate evidence to determine if the benefits outweigh the harms of lung cancer screening with LDCT, CT acquisition variables set to reduce exposure to an average effective dose of 1.5 millisieverts in the Medicare population, if at least intermediate confidence, score greater than or equal to 2.5. How confident are you that there is adequate evidence to determine that screening in asymptomatic high-risk adults over 74 years of age improves health outcomes? B, how confident are you that there is adequate evidence to determine that annual screening beyond 3 annual LDCT screens improves health outcomes? And C, how confident are you that there is adequate evidence to determine that a lung cancer screening program implemented outside a clinical trial improves health outcomes? Voting question number 2, how confident are you that the harms of lung cancer screening with LDCT average effective radiation dose of 1.5 millisieverts, if implemented in the Medicare population, will be minimized? And the discussion question related to that, what harms are likely to be relevant in the Medicare population, including A, harms from the scan itself, LDCT itself, B, harms from follow-up diagnostic evaluation of findings in the lungs and incidental findings outside the lungs, and C, harms from treatment arising from positive and false positive results. What provider and facility criteria or protocols are helpful in minimizing harms? The last voting question number 3, how confident are you that clinically significant evidence gaps remain regarding the use of LDCT, average effective dose of 1.5 millisieverts for lung cancer screening in the Medicare population outside a clinical trial? And the discussion question with that is if there is at least intermediate confidence score greater than or equal to 2.5, please discuss any significant gaps identified and how CMS might support their closure. Thank you very much.
Thank you, Dr. Chin.
There's some additional discussion questions, so I should read them. Please discuss whether these or other topics should be considered for further research in the beneficiary population. If yes, why? I, risk factors and risk factors criteria for eligibility of screening asymptomatic individuals, frequency and duration of testing, what impact will adherence have on lung cancer detection. National lung screening trial adherence was 95%. Definition of a positive screen and variability of false positives and how false positives should be resolved. the rate, classification, and standard evaluation of incidental findings, and the impact of lung cancer screening on smoking cessation rates.
Okay. Thanks very much, Dr. Chin. That was a great presentation for the background of our evidence today, as well as the voting questions and the discussion questions. And I will also note that even with the backup slides, you finished before your allotted time and set a great example for the rest of the morning. So the next speaker is Dr. Paul Pinsky, who's the division from the Division of Cancer Prevention at the National Cancer Institute at the National Institutes of Health. And Dr. Pinsky, you have 20 minutes.
Thank you. So Dr. Chin mentioned the NLST, or National Lung Screening Trial, and briefly some of the main design and findings. But I'm going to go into some detail of the design of the trial and the findings, and also try to emphasize some points related to dissemination into the population setting. I do not have any conflicts of interest. So the basic design of the NLST was a randomized trial where subjects were randomized to either low-dose CT or chest radiograph over 3 annual rounds of screening, with a total follow-up of 6 to 7 years, so about 3 to 4 years after the last screen, they were continued to be followed. The issue of the diagnostic follow-up of positive screens is important and relevant for how it would translate into population settings. So we did not have a trial-wide algorithm for diagnostic follow-up in NLST. The study radiologists did give recommendations based on their clinical judgment. But overall, the diagnostic follow-up, as well as treatment, was conducted outside of the auspices of the NLST. The primary outcome was lung cancer-specific mortality, and secondary outcomes of all-cause mortality, lung cancer incidence, and stage distribution. The eligibility criteria, which I think the last speaker mentioned briefly, basically 30-plus pack years of cigarette smoking and being a current smoker or having quit within 15 years, and then age 55 to 74. Those were the major criteria, along with some others. It's interesting to see how those criteria played out in terms of the actual NLST trial population. So we see roughly half were current smokers and half former smokers, and that's the distribution of time since quit. The median pack year is 48, and the 25th to 75th percentile there, 39 to 66. So the majority of subjects had well more than the 30 pack year minimum. So 75% had at least 39 pack years. It's very relevant for this discussion what the age distribution was. So in NLST, 25% about were 65 plus Medicare age. Now it's also of interest to compare the NLST population to an estimate of, for the whole U.S., what the NLST eligible population would be. So NLST was a little bit underrepresented in terms of current smokers. Median pack years was similar, and it was also younger than the overall U.S. population that would meet the NLST eligibility criteria. So overall in the U.S. it would be about 35% would be 65 plus. The radiologist requirements, board certified, fairly standard. The last bullet there, we did come up with a dedicated NLST training set of images that all the NLST radiologists had to look at before the trial. In terms of the CT settings for the NLST protocol, KVP 120 to 140, MAS 40 to 80, depending on participant body size and other parameters. There was a study of trying to estimate what the effective radiation dose was in NLST. And this was based on the estimated radiation dose using techniques to image the average-sized person in NLST. So this is essentially based on an MAS of about 40. And we see an average effective dose of 1.4 millisieverts. Now, in practice, about 25% of the time, the MAS was 70 or greater in NLST due to larger patients. So this 1.4 is probably a little underestimate of the average actual effective dose among NLST subjects. It could be a little higher. So moving on to the actual screening, and a very important point is what the definition of a positive screen was. So the basic definition was a non-calcified nodule that had a maximum diameter of at least 4 millimeters. Other suspicious findings could also result in a positive screen, but the bullet in the bottom there shows that 98% of positive screens did have at least one 4 millimeter nodule. So that was essentially what the definition was. Another important point, and especially for translating into the population setting, is that of the third-year final screen, that an NCN that was stable for 2 years could be classified as a negative result at the discretion of the radiologist. And as you'll see, that affected the positivity and the false positivity rate on that final screen. So now I'm going to go into the major NLST results, starting with the screen adherence and positivity, diagnostic follow-up of positive screens, then lung cancer incidence and stage, mortality, the primary outcome, both lung cancer specific and all-cause mortality, a secondary outcome, then some screening center and radiologist factors, and finally results stratified by age 65 plus or less than 65, which are very relevant to this discussion. So at the bottom there, you see the overall adherence to LDC screening was very high at 95%. In terms of the screen positivity, it was 27% at baseline and roughly the same at year 1. But it's of interest that at year 1, over half of the positive screens actually were positive screen with no significant change. So that means the nodule was stable and did not change from the T0 to the T1 screen in the estimation of the radiologist, and there were no new nodules. Now, at the year 2 screen, where the radiologist had the discretion to not call a stable nodule as a positive screen, there was a substantial decrease in the positivity rate to 16.8%. But even there, over half of the screens actually did not have a significant change, and that's because the radiologists had the discretion whether to call it positive or not, and some still wanted to call it a positive screen. But this is relevant because in a population setting, at a steady state, most people would have a 2-year history of screening, and you have the option of assessing stability most of the time in the population setting as opposed to the trial. So in terms of the diagnostic follow-up of positive screens, separated into the baseline and year 1 and 2 screens because there was differential patterns. So at the baseline screen, 90% had some kind of diagnostic follow-up, and about 3/4 had a chest CT as part of the diagnostic follow-up. Invasive procedures, especially in subjects found not to have cancer, were quite low at about 3.7% there, and surgical procedures even rare at 1.3%. Moving to the year 1 and 2 screens, there was a lower percentage who had any diagnostic follow-up, lower percentage that had chest CT, only about a little more than a third, 34%. And that was largely because a lot of the positive screens at year 1 and 2 had a positive screen with no change in the nodule essentially a stable nodule. Moving on to the positive predictive value, it was about 4% at each screening period. And some people may have heard this figure that 96% false positive rate, and that's basically 1 minus the PPV. If you look at the prior positivity rates of 27% there, since 96% of those were actually false positives, the false positive rate is essentially the same as the positive rate. So quite a high false positive rate, especially at the first and second screen. Finally, if we look at the last line, which is complications of diagnostic follow-up, and looking at those with no cancer, the rate is fairly low at 0.3 to 0.4%. So let's look at the outcome, one of the secondary outcomes, which was lung cancer incidence and stage. There was a small excess of diagnosed cancers in the CT arm, quite a large excess of screen-detected cancers, over twice as many screen-detected cancers in the CT arm. And when you go to stage 1 lung cancers, again, there's a large increase in stage 1 cancers and screen-detected stage 1 cancers in the CT arm. Also important is that there's an absolute decrease in stage 3 and 4 cancers in the CT arm. So about a little over 100 fewer stage 3 and 4 cancers in the CT arm. Now, an important issue in terms of the harms of screening, in addition to false positives, is overdiagnosis. And in a randomized trial setting, one way to quantify overdiagnosis is the excess CT arm cancers as a fraction of the screen-detected cancers by CT. So there was 119 excess cancers in the CT arm, and out of the 649 screen-detected cancers, that's 18%. So we report a overdiagnosis rate of 18% defined in that way. So lung cancer-specific mortality, these are the rates. The figure that most people are familiar with is the relative risk of 0.80, which is equivalent to a 20% mortality benefit. That was reported in the New England Journal paper in 2011. The end of follow-up was December 31st, 2009. For the paper, in terms of lung cancer mortality, but not overall mortality, we used a January 15th deadline to be able to do all the endpoint verification, which certifies the cause of death. So when we use all the data through December 31st, when we had time to do all the endpoint verification, there's a little difference in the rate ratio there. The number needed to screen was similar, though. And again, the number needed to screen is defined as the number needed to screen to prevent 1 lung cancer death. All-cause mortality, we actually found a significant reduction in total deaths or all-cause mortality. The rate ratio there is equivalent to a 6.7% mortality decline. It's actually very rare in a screening trial to find a significant difference in all-cause mortality. In NLST, we had a very high-risk population for a very high-risk cancer. So that was the major reason. A fairly high percentage of all the deaths were from lung cancer. So if we exclude lung cancer deaths, there was no significant all-cause mortality or other-cause mortality decline. So I want to move now a little bit to some of the center and radiologist factors. So one interesting thing, and which I think would have implications for dissemination into the population, was extreme variability in radiologist false positive rates. There's always variability in image interpretation, but this might be more than, say, for mammography or other modalities. So we see that among 112 NLST radiologists who had at least 100 CT interpretations, there were some who had a false positive rate of 10% or lower, and others who were up at 50% or higher. So a very large variability. This, as I mentioned, in part of the design, the radiologists made recommendations for follow-up of positive screens. So if we look at the baseline positive screen stratified by nodule size, you see there's a fair amount of variability in the radiologist's recommendations. So this is just to emphasize that there was no standard algorithm that the radiologist had to use to say 4 to 6 millimeter, you had to recommend one specific thing. There was variety across radiologists, to some extent within radiologists, even within these strata, about what the diagnostic follow-up should be. Another issue which is very important in terms of translating to population setting is the idea that NLST was carried out in non-representative settings, academic settings primarily. So it's a little bit of a judgment call whether a site is called academic or not, but we made a judgment, and by that most of the centers were academic, but the non-academic sites tended to be the larger sites. So in terms of percentage of subjects, a little over a third of subjects actually were screened at the non-academic sites. If you look at specificity and sensitivity, they're similar between academic and non-academic, a little higher specificity in one, a little higher sensitivity in the other. But a very important point is this is just the screening per se. So for screening to be effective, obviously you have to have diagnostic follow-up, you have to have the treatment. So the diagnostic follow-up and treatment, even at an academic site, was not necessarily carried out at that center. We did not collect rigorous information on this for the trial, but anecdotally, at least for a lot of the academic centers, we estimate that the majority of the diagnostic follow-up was not done at that center, but it was done at patients' local community facilities. So that's an important point to think about. So finally, getting to results by age, which is an important discussion here. There were some differences, fairly minor. Adherence was high in each age group. A little higher positive screen rate in the older population. Something which I didn't mention before is this idea of significant abnormalities that are not related to suspicion of lung cancer. And that's going to be an issue going forward, how to deal with these non-lung abnormalities. But in terms of significant abnormality, again, as might be expected, a little higher in the older population. The positive predictive value was higher, and this is in large part due to the higher incidence rate in the older age group. Complications were not significantly different. Finally, if we look at the rate ratio for lung cancer and all-cause mortality, there was no significant difference by age. So I just want to spend the last minutes discussing my take on one of the questions that dealt with extending to greater than 3 screens that we saw in NLST. So some arguments in favor of extending beyond the 3 annual screens in terms of population screening. Trial screening scenarios, including NLST, are usually based on the logistics of the trial, how to do the trial as quickly and inexpensively as possible, and they're not intended to be the basis of a population regimen. So it was never intended that because NLST was 3 screens, so that would be necessarily what would be recommended should the trial be successful. For example, mammography, when Medicare coverage was introduced, there were a number of trials. I don't think any had more than 5 or 6 screening rounds, and even though mammography is done over 20 or 25 screening rounds. There's a problem of tracking CT screens prior to Medicare entry, so they wouldn't know if you had had a number of prior screens. The harms, false positives, radiation, can in large part, or at least some part, be projected from the shorter screening regimens. And modeling efforts have attempted to extrapolate benefits to longer-term screening, and there was one prominent modeling effort that accompanied the task force guidelines in the annals that extrapolated to a population screening setting. There are some caveats, though. One, the NLST was 1/3 prevalent screening, meaning the baseline screen, and long-term population screening would primarily be repeat screens, so there might be different outcomes. And NLST, as I mentioned before, had only 1 of 3 rounds with a 2-year nodule history where you could judge a stable nodule. And population screens, you generally have that history. So you may have a potential of reducing the false positive rate because a lot of these nodules would be stable. And the models that extrapolate benefits and harms, of course, must be viewed with caution, as with all models. And the long-term adherence with screening, which screening adherence was very high in NLST, but the long-term adherence in the general population is unknown. Thank you.
Thanks very much, Dr. Pinsky. And our next speaker is Dr. Peter Bach, who is an attending physician and director of the Center for Health Policy and Outcomes at Memorial Sloan Kettering. I'll just note that we will be taking questions and answers later on in the session.
Great. Thanks, Rita. And thank you very much for having me. I'm excited to be here. I've been working in this field for a while, and I'm here to request that the MEDCAC consider the evidence and that CMS consider covering LDCT in the Medicare population. I've asked for a couple of provisions, that it be done in places with a certain level of expertise, sort of TBD, what that constitutes, that a registry be put in place so some of the unanswered questions that could be answered in observational context are, that there's a qualification of sites that include informed decision making as well. So those are sort of the parameters. I think there's an opportunity to do this right. This is a promising technology with both high costs and high risks, but I also feel if we don't do it right now, it's a genie that certainly won't be able to be stuffed back into the bottle. I have no financial conflicts of interest. I was the lead of 3 separate guidelines, including the multi-society guideline effort that Mike Gould mentioned. I am a member of the MEDCAC. I'm here on my own today, and I'm going to discuss off-label use of the CT scanner. The CT scanner is only labeled for clinical use. Number of the issues have been addressed by Paul already. I'm going to talk about extrapolating the evidence of the NLST in the following domains. I'm also going to talk, if you look at the bottom, about harm minimization opportunities and about individualized decision making in the context of large risk variation. The basic questions about extrapolation, Paul has touched on them to some extent. Was this group study generalizable? Are the findings in terms of mortality, false positives, and adherence generalizable? Were the settings generalizable? And some basic questions of things that we can't even know enough to know if they are generalizable. As Paul noted, the NLST showed in a highly regulated randomized trial a reduction in the deaths from lung cancer in people having low-dose CT relative to chest X-ray, as shown on this slide. It had, as Paul noted, partial overlap with the population that would have been in the study had it been randomly sampled from people with the same risk factors the NLST included. As Paul noted, it underrepresented people, particularly in the older age band. If they had randomly sampled people, they would have had about 14% study sample between the 70 and 74 age band, and they came in at about 9%. And as Paul already noted, only about 25% of the NLST study subjects were in the Medicare eligible age group. It also had an overeducated population relative to the tobacco-using population as a whole. Both of those things, I would speculate, would tend to make CT screening look more efficacious and less harmful than if the population had been representative. If you contemplate the impact or the role of NLST and as it overlaps the population of people dying of lung cancer, you can see on this slide there is, again, partial overlap. The blue histogram represents deaths from lung cancer by age at death in the chest X-ray arm, essentially the observational arm of the NLST. The red histogram shows deaths from lung cancer in the SEER data in the US. So partial overlap. Lung cancer is primarily a disease of the elderly. NLST was primarily a study of somewhat younger people. Paul noted this as well. The care settings are not typical. I concede the point, certainly, that much of the care spread from these academic centers, many of which were NCI designated, into the community, and that's a terrific thing that we'll learn more about as we study the NLST data. But nevertheless, these are the sorts of settings that have particular expertise. I think we have at least 2 decades of research demonstrating that care in centers like these is both less harmful and more efficacious, leading to questions about extrapolation to the community. Paul showed a nice slide at the radiologist level from the NLST. This is a slide looking at the false positive rates of all the published studies from our recent JAMA article. In the top is the RCTs, and the bottom is the observational arms. False positive rates vary, as do the lung cancer detection rates shown in the dark part of each of these bars. A pooled average of these represents about 20% of false positive rate. That's just one number. It really does depend on care setting. This is the clinical problem. 19 CTs of 20 have a false positive. 1 has lung cancer. That's the average I just showed you on the prior slide. I won't pimp anyone, although I'm looking at Mike Gould. He probably has a sense of which one is cancer here, but it nevertheless illustrates the basic problem. This is the cancer. Everyone else is potentially harmed. The rates of follow-up procedures and invasive procedures for lung cancer are also inconsistent across the studies. There's good news on this slide as well. If you look at the bar charts, when biopsies were performed and there's a black area, that means what was found was malignant. The gray area means interventions for things that ended up not being cancer, essentially another source of harm. Please note that the x-axis only stops at 8% here. So these are not high rates, they're single-digit rates. You'll see this in another slide deck as well. There are actually 4 randomized trials shown above the NLST in this table are 3 smaller trials. These trials have weaknesses. They're all in the evidence review. They had smaller sample size and inconsistent follow-up. There's actually some data ascertainment problems as well. But nevertheless, the NLST result has not been reproduced in 3 other randomized trials in terms of lung cancer mortality reduction. That is not the case in terms of the effective cause of death on other causes than lung cancer. Paul correctly reported that the NLST reduced overall causes of death, but that was purely through mediation reduction death from lung cancer. If you look at the rate of death from causes other than lung cancer in the NLST and these other 4 studies, there is no evidence that CT screening reduces the rate of death from anything like cardiac disease or any other cause. We know little about the incidental findings. Paul again alluded to this. This is a graph from the Leahy Clinic, which I think is a study that's an ongoing that you'll hear more about. This is just a pie chart of all the other stuff that is found from CT screening. We don't know if these findings are incidentalomas leading to harm, really great opportunities to improve outcome, or anything in between. We need to understand this better. As I noted, we do know that none of these studies showed an overall reduction in death from causes other than lung cancer. These might be such things. Adherence, as Paul noted, is inconsistent, but was high in the NLST. And then we have some important questions. What to do where we don't have data? What about unstudied groups? What about unstudied durations? We don't have data for screening over 74, and in fact, the NLST is underpowered in the over 65 group. We don't have data for longer duration. We don't have data for real-world settings. What can we infer, and can we trust our models? As I've noted, the age band in NLST is low. With respect to the population that's both recommended by the USPSTF and the Medicare eligible population. Fewer than 12% of subjects over age 70, and it's actually 9%. There's something good about going on to older ages. The risk of lung cancer rises. Shown here are 2 prototypical patients. Somebody who's 80 with a 50-pack year smoking history has about an 11-time greater risk of death from lung cancer than somebody who would barely be eligible through NLST entry criteria, 55-year-old with 30-pack years. But there are bad things that happen, too, with advancing age in terms of the net benefit trade-off. Rising risks of false positives, life expectancy reductions, and risk of surgical death. All 3 of those things are shown empirically on this slide. These are the 3 bad trends, if you will, as you go into advanced age in terms of net benefit trade-off. The blue line shows a declining probability or declining life expectancy by age for smokers. That's based on CISNET models for smokers, not for people with lung cancer, but for smokers with any smoking history. NLST population would skew even older. Life expectancy would be marginally lower. The rising orange line shows the false positive rate. This is from the NLST data. This is analysis we did by age. We've extrapolated beyond the NLST data. Extrapolation or not, that's the dashed line, doesn't matter. The point is obvious. The harms that are related to false positives will rise with advancing age. And then shown in the yellow is data and back extrapolation from SEER Medicare data, 30-day mortality in SEER for lobectomy or sublobectomy for stage 1-2 non-small cell lung cancer. As people age, unfortunately, their risks from surgery rise, and even mortality at 30 days rises. There are some questions about longer duration. We are dependent on models to look at this. And from the CISNET group, I've taken the view, and I wrote one of the 2 editorials that went with the CISNET paper and the task force, that the CISNET models probably are not adequate to determine what will happen over a long period of time with screening. It's not out of disrespect, it's just an empiric observation. The basic argument is there were 5 separate modeling groups. Those groups each produced estimates, and they matched so poorly to one another that I think we're left wondering, are any of these right? But for sure, 4 of the 5 have to be wrong because they're not overlap. And the variation in what these models produced was extremely wide. One model, for example, per 100,000 people estimated 2,000 life years gained in the population, another 5x that. One model, in terms of overdiagnosis, estimated about 72 people, another 5 or 6 times that. These models, because they don't agree, probably can't be relied on. And they also don't mimic. The first test of a model is does it mimic what you can actually observe in real nature, and they don't. Here's a figure from the ARC technical report of the CISNET models. Shown on the black graph is the cumulative risk ratio of deaths from lung cancer in the CT arm versus chest x-ray arm. Pardon me, other way around. Chest x-ray versus CT, so it's greater than 1. Over time, it's cumulative. You'll see an immediate effective CT screening, more deaths in the chest x-ray arm, and then this smooth plot. All of these other dots, X's, etc., are the different models. You'll note that at the beginning, they don't match. They didn't hit the target. You might look at this and say, oh, well, by 6 years at the end, they did. So we should all be comfortable that as we extrapolate further, we're good. Note this. The problem with that is it's clear in the technical report that these models were all post hoc recalibrated to match at 6 years. I'm unable to find, and this is not a critique of the methods, please don't misunderstand me, I'm unable to find to what extent these things had to be recalibrated. But if you don't hit the target, that means you can't trust the data going forward. In terms of harm minimization, there's some important good stuff going on. There's numerous efforts to codify approaches to false positives, the lung rads you'll hear about. There's efforts underway to create standards. But there's also some some misdirection. Statements that we can reduce false positives, I think, are plagued with some problems. And there's also trusted lists of screening sites, which, to be honest, I think can't be trusted. In terms of the reduction of false positives, I just want to note that there's a recent study from LCAP, and perhaps Claudia will talk about it, where they talk about changing the threshold. That's the study shown here on the far right. Please note that the median age in this study was 59. The median pack years, this red dot, was about 25. In the NLST, the median pack years was 48. So the data coming from that, which extrapolate to the number of cancers found and things like that, has little relevance to the question at hand. Here's a pie chart we generated in my office. We just took the list of trusted sites for the Lung Cancer Alliance. We stopped when we got about halfway into the alphabet. These sites publish their screening eligibility criteria. The small blue slice of 19% meets the multi-society guidelines for eligibility. The orange meets the USPSTF. Every other site enrolls people who don't meet those criteria. Here's an example, a sample we chose. The John Muir Health System. Read the eligibility criteria at the bottom. They'll screen people between 40 and 80 who have a long history of smoking, or people who have an immediate family member with lung cancer, or an occupational exposure. That doesn't meet any recommendation. Every guideline recommends shared decision-making, and I'm asking Medicare to contemplate that in the context of covering CT screening. Why? Risk of lung cancer varies in a predictable fashion, and so does the benefit. Decision tools are in development, and this is my fancy slide showing that, in fact, every guideline recommends shared decision-making. I'm very proud of that. The risk variation issue, I'm going to show you a paper from the New England Journal, empiric data from the NLST. This is organized in the following fashion. To the left is the hypothetical scenario in which you screen only the top quintile of patients based on the predicted risk of lung cancer in the NLST. You'll notice just doing that gets you 38% of the lung cancer deaths in the population. And then as you enroll lower and lower risk people within the study, you reach the cumulative number. Bottom right, the ratio of false positives to prevented lung cancer deaths is most favorable, again, focusing on the highest risk patients. This is a paper that Michael Gould and I had doing the same thing. This is, again, through a modeling study. The top 3 groups are NLST people, the bottom two are non-NLST eligible. Focus only, because of limitations of time, on the right-hand column. If you go to an individual who fits the typical participant, the number needed to screen, you can tell that person, about 256 people like you need to be screened. The minimum eligible person was 1,200. Going down to the fourth line, the NCCN recommendation, which you'll hear more about today, the minimum eligible person for NCCN, 3,000 people need to be screened in order to prevent one death from lung cancer. 1/10 as efficacious as the mean in the NLST. There are some decision tools that are under piloting. Shown here on the left is a handout from the VA, which shows two scenarios. To the right, not being screened using the NLST estimate of 1 in 320. To the left, the benefits. The 3 prevented deaths in the green circle and the various harms. There's an active grant from PCORI down to MD Anderson using to develop video-based decision aids. And then this bottom right is a screenshot from our very pedestrian decision aid that's on the Sloan Kettering website, but which will give you tailored estimates per 1,000 people. Here's some thoughts and your questions. Do benefits outweigh harms in the Medicare population? Remember, benefits and harms vary by individual based on risk factors, life expectancy, and preferences. What about high-risk adults over 74 years of age? There's no empiric data. There's minimal empiric data over 70. Annual screening beyond 3 LDCT screens, there's no empiric data. The models, I believe, are not reliable, and they're fundamentally not in agreement. And outside a clinical study, does it improve health outcomes? Again, no meaningful outcome data and reasons for concerns about selecting setting. There are good things happening on harm minimization. The American College of Radiology efforts, a BI-RADS type effort is one thing that is going on. But there's serious concerns in my mind, and I showed you a slide of a place advertising CT screening, that coverage from Medicare will lead to explosion of inappropriate activities driven by probably a mix of both good intentions and entrepreneurialism. And remember that the coding and capturing of smoking history as an eligibility criterion is something we have no experience with, doesn't fall under the meaningful use criteria, and we have a long history of behavior by doctors coding things like minimal bowel symptoms to do colonoscopy screening as our backdrop for this. How confident are you that clinically significant evidence gaps remain regarding the use of LDCT? And again, large groups of potentially eligible patients not studied, and they tend to be populations who may derive less benefit and be harmed more. The elderly, the less well-educated, etc. Thank you very much for your attention.
Thanks very much, Dr. Bach. That was very helpful. And next we have Lori Fenton Ambrose, who's the president and the CEO of the Lung Cancer Alliance. You have 15 minutes.
Good morning. My name is Lori Fenton Ambrose, and I'm president and CEO of Lung Cancer Alliance. I have no personal conflicts to disclose, and Lung Cancer Alliance has received the grants listed. It is an extraordinary privilege for me to be here today to represent this community before the panel and to ensure that the people behind the numbers and their voices are heard. I can tell you that they know what is at stake. It is a breakthrough they have long advocated for. They know we can transform one of the most lethal cancers in our society to a curable one with lung cancer screening, and they know there is no reason to further delay or deny them this life-saving benefit. It's also an honor for Lung Cancer Alliance to be a part of the largest coalition that has ever assembled on their behalf. Standing shoulder to shoulder are the nation's leading experts in the field that include multiple professional societies, public health organizations, hospital centers, industry, health equity leaders, women's health organizations, and patient advocates. We have carefully considered this evidence. We have been developing and deploying best practices in the field today, and we are unified and in agreement and support national coverage for lung cancer screening for our Medicare population. With over 160,000 people dying each year, we have lost roughly 500,000 people to this disease since the National Lung Screening Trial was halted in 2010. The vast majority of the cases were detected late stage, and the majority of the cases diagnosed were and will continue to be in people over the age 65. There is no other proven way to find and detect lung cancer at its early stage when it is most treatable and curable. Expeditious action is not only reasonable, necessary, and appropriate, it is warranted. It is a public health imperative for our nation and for our Medicare population. We have sufficient evidence. Lung cancer screening has been more rigorously tested and reviewed prior to implementation than any other screening method, a combined total of over 30 years. The NLST, as we've heard earlier this morning, one of the largest randomized controlled trials ever carried out by the NCI, with over 53,000 participants in 33 sites over 8 years, with nearly $250 million federal dollars spent, confirmed the mortality benefit with only 3 rounds of screening. If time and funding had permitted additional rounds of screening, the mortality benefit would have been even greater. We have the benefit of the USPSTF recommendation, which conducted an independent 2-year evidence review resulting in a B grade for a population 55 to 80 with a heavy smoking history. That means right now, the non-Medicare population, lung cancer screening is an essential health benefit. We also have the benefit of the pioneering efforts of the International Early Lung Cancer Action Program, over 20 years of observational research that includes the largest patient registry for CT screening for lung cancer in the world. Its seminal work has led to the development of a well-defined screening protocol that externally validates the conclusions of the NLST and proves responsible screening can be achieved with minimal harm in a variety of settings, including community hospitals. The National Comprehensive Cancer Network has been providing updated, consensus-driven, gold standard clinical guidance on lung cancer screening to doctors and patients since the NLST, guiding screening practices at this very moment. And based on all of this evidence and clinical work underway, an unprecedented coalition of multi-society, multidisciplinary stakeholders have joined together in a public statement of support for full and expeditious coverage for this preventive screening service. The threshold of evidence has been met to support Medicare coverage for lung cancer screening within the USPSTF population. So let's consider 3 elements: educating the general public about screening and risk, implementing responsible best practices, and supporting quality improvement with the collection of data. First, it's essential to properly educate the public about lung cancer risk and ensure that people have the tools and information they need to make an informed decision about whether screening is right for them. As important is laying out what constitutes responsible care and guiding those people only to places conducting responsible screening. Lung Cancer Alliance, among others, has developed a risk navigator tool and tailored educational materials that have already been utilized by thousands of people. We have already launched public awareness campaigns encouraging people to live more moments, targeting this outreach to areas where our screening centers of excellence are located. We're involved with training opportunities, including webinars and CMEs, and we have also been working with higher risk populations, collaborating with the Department of Defense, the VA, and Veterans Service organizations to inform our military and veterans populations who are at even greater risk than civilians and to provide them life-saving care. In fact, 5 of the largest DoD treatment facilities, led by the incredible team At Walter Reed are screening following guiding principles of our National Framework of Excellence and Lung Cancer Screening and Continuum of Care. Which leads me to the second element and the implementation of best practices. The full integration of lung cancer screening into clinical practice is well positioned today because of the thoughtful and careful pre-planning that began immediately following the halting of the NLST in 2010. Unlike our other experiences with other screenings, we were and still are ahead of the curve. A multidisciplinary team of doctors, many of whom are in this room today, moved rapidly and thoughtfully to create a blueprint that would launch a community of practice that promotes responsible screening as its norm and would inoculate against substandard care. And this blueprint is our national framework. It has done just that. The national framework has elevated the national dialogue about responsible screening and created a clinical culture and mindset around best practices today. The principles that guide the national framework include informing the patient on risks and benefits of screening, adhering to best published practices, coordinating care with a multidisciplinary team, including smoking cessation counseling, providing prompt reporting to the patient and referring physician, and supporting quality improvement within the process and collecting data. I am proud to say that this growing network of centers of excellence has served as a de facto national pilot program. When these slides were submitted a month ago, we had 169 centers. Today, we have 172 centers in 37 states and in Washington, D.C. This network is demonstrating that high-quality, responsible screening in practice is scalable, is replicable, and in a variety of settings that go beyond NLST sites. In fact, approximately 70% are not associated with academic medical centers, yet they are delivering high-quality care. And I want to take this moment to acknowledge and thank all of the doctors and the nurses, the healthcare teams, referring physicians, including family physicians, who considered the evidence, understood its impact, and moved forward without delay. They are delivering responsible care in the real world, in real time, for real people. We trust them. And for those people who currently smoke, screening's added benefit is that it provides a teachable moment to help them quit through more personalized and targeted and frequent interventions to achieve success, like the patients at Phoebe Putney Memorial Hospital in Albany, Georgia, who shared recently that because of their experience with the screening process, were able to quit after more than 30 years of smoking. The cost utility of smoking cessation within screening has been analyzed, and I'm thrilled Bruce Pyenson will speak to this and other issues related to cost in his upcoming presentation. So now, let's turn to the third element, which is supporting quality improvement with the collection of data. We support coordinating and building upon existing databases to provide ongoing quality assessment to make continuous improvements to the process. And as screening moves forward, we have the benefit of existing registries and data collection, assuring right now the lowest incidence of unnecessary testing or procedures, as well as optimal outcomes of any invasive testing or surgery that is indicated. An example of how we have already improved and refined the screening process: in February 2013, the publication of an ILCAP paper on nodule size and malignancy based on 15 years of structured reporting and analysis led to the revised recommendation to a 6 millimeter threshold for a positive scan. Summer 2013, The recommendation was carefully considered and incorporated in the NCCN clinical guidelines, and the result is that this new threshold will significantly reduce the number of false positives without a significant reduction in efficacy. To the question regarding the collection of additional evidence, to make screening for the USPSTF recommended population contingent on the collection of even more evidence cannot be rationally explained or justified. The most important questions that have been raised have been answered. Radiation dosage has been reduced consistent with the level of mammography. As I've just referenced, we have made refinements in protocols, adjustments to the threshold nodule size, reducing false positive rates. And screening is already being responsibly implemented within the community and for people over the age of 65. In fact, nearly half the people being screened at our centers of excellence are Medicare beneficiaries. Coverage with evidence will not lead to any additional information that will fundamentally change the elements and the practice of responsible lung cancer screening for our seniors. But what it will do, and make no mistake, it will cost time, money, and their lives. Now, let's talk about what's really at stake, and that's equity and access. The Affordable Care Act makes lung cancer screening an essential health benefit. The vast majority of private insurers by this time next year will include screening in their coverage. Some already have. If Medicare does not cover screening, we will be faced with the ludicrous situation of a break in coverage at age 65, when risk is greatest. If we limit lung cancer screening only to large academic medical centers or NCI-designated cancer centers, as contemplated in the request for coverage with evidence, people in areas of high risk will face significant barriers to access. Let's consider these two maps. This map shows where we have the highest incidence rates of lung cancer in the country. This map shows where the NCI-designated cancer centers are located. If, for example, we were to restrict screening only to these types of centers, huge swaths of the country would be left out. Even worse, we disenfranchise the very community hospitals that are leading the way and saving lives right now. Beyond the centers that you'll hear today, Sanford Health in Sioux Falls, South Dakota, Mary Bird Perkins in Baton Rouge, Louisiana, St. Joseph Center in St. Charles, Missouri, Gibson Cancer Center in Spartanburg, South Carolina.
Time to wrap up.
Pardon me?
It's time to wrap up.
Thank you. So, in closing, much has happened since the NLST in 2007. We've witnessed advancements in technology, in reductions in radiation, and surgical improvements, all contributing to further maximizing this benefit and minimizing the harms. And so to return to the people, in closing, for too long, a black cloud of despair and indifference has hovered over this community. Yet now we have a convergence of solid evidence and best practices that bring tangible hope for their survival. The enormity of the impact cannot be overstated. There is no need to create any additional barriers to this life-saving benefit that would result in a patchwork system for our Medicare population. Thank you.
Thank you very much. Thank you, and I'd like to now introduce our next speaker is Dr. Doug Campos-Outcult. He's the chair of the Department of Family, Community, and Preventive Medicine at the University of Arizona College of Medicine. You have 15 minutes.
Oh, thank you. I'm happy to be here today. I was asked to come and explain the position taken by the American Academy of Family Physicians. I am a part-time staff person for the Academy, serve as a scientific analyst for them. For the past 7 years, I've been the AAFP liaison to the U.S. Preventive Services Task Force. I have no financial or intellectual conflicts. I would mention that I do serve on the Advisory Committee on Immunization Practices at the CDC, and also on a group that evaluates genomic tests at the CDC. Neither of those have been involved with this issue. So let me just explain a minute about the American Academy of Family Physicians. We are one of the largest organizations of primary care physicians, us and the internists. And our physicians are located geographically around the country at the same rate as the population, so that the same proportion of family physicians are in rural areas as the population of the U.S. So family physicians are distributed around the country, and family physicians see the impact at a local level of recommendations made by national organizations for all types of recommendations. And we're asked to weigh in on a number of different topics. For preventive services, we tend to adopt recommendations that come out of the United States Preventive Services Task Force, and these are for screening, counseling, and preventive medications. We rarely disagree with the task force, but we have at times done that. For instance, we think HIV testing universally should start at age 18, not 15, and we did disagree with them on the lung cancer screening, and our Commission on Health of the Public and Science thought that at this point in time the evidence rating should be an I and not a B, meaning insufficient evidence. We adopt ACIP recommendations for immunizations, and we tend to adopt EGAP recommendations on genomic prevention issues only, but there's been only one of those so far. So when our commission looked at the lung cancer screening issue, they had 5 concerns, and it was the following. First, the recommendation was based largely on one large study, albeit large randomized control trial of high quality. Our commission felt that the conditions of the National Lung Screening Trial were unlikely to be replicated in community settings. The age of the participants of the trial, you've already heard, 75% were below the age of 65 in relatively good health. A conservative protocol for working up positive findings, although we've heard actually that there was no protocol, so that's somewhat reassuring. And we felt that there would be much less benefit and more harms when this was implemented at a community-wide setting. The third concern had to do with modeling and extending the number of tests beyond what went on at the NLST, as well as the age range of the population in the NLST. A fourth concern was that a current smoker who started in the screening recommendation at age 55 could potentially get 25 annual CT scans, and this gave our members a great deal of concern. And there was unknown harms from accumulated radiation and follow-up for positive findings after 25 scans. The likelihood of having a false positive is pretty much 100% there. And the fifth concern was there was no cost-benefit analysis. So we looked at the evidence reports that were published on the website of the U.S. Preventive Services Task Force, and as was mentioned before, there were 4 studies that were looked at, the NLST and then 3 European studies. And the other studies have confidence intervals that cross the relative risk of 1, meaning no significant differences found. Now, as was mentioned before, these were smaller studies and somewhat lower quality. But the normal thing to do, which the evidence report did, was to perform a meta-analysis in the forest plot and combine these studies to look at the overall results. And this was an evidence report that was a separate evidence report, which is also on the website of the task force. And if you look at this meta-analysis of lung cancer mortality, it does show that when you do a meta-analysis of they actually eliminated one of the 4 studies here, the low-quality one, that the meta-analysis lung cancer mortality does end up in the range of about 0.8, or about a 20% reduction. If you look at the all-cause mortality, you find the same results of the 4 studies. 3 of them don't show any difference. But when you do the meta-analysis here when you add the 3 highest quality studies, there is no difference in all-cause mortality. So that has some implications as to potential complications from the interventions themselves. So the AAFP Commission on Health of the Public and Science looked at all of this and considered 3 different possibilities. One was a B recommendation for 3 annual tests for those who meet certain criteria, and that we would either determine that exams past 3 would either be a C, meaning individual discussion and decision making, or an I, meaning insufficient evidence. The second possibility was that we would just say it's a C recommendation for everybody. A C recommendation means individual decision making where the benefits and harms are kind of equally balanced, but there's some people who could benefit, and that you get to that through individual discussions. And the third option we considered was an I statement, meaning insufficient evidence. And our commission chose the insufficient evidence. We felt that at this point in time there was just not enough evidence to assess the harms in particular, and we were not confident that the benefits in community settings would equal what was achieved in the NLST. During the comment period, when the draft recommendations, or after when the draft recommendations were posted, we did make a couple of comments about possibly restricting the recommendation to clinical settings that meet certain criteria and making a clear protocol for or suggestions for following up on positive findings. And then we also suggested considering a better risk-benefit patient profiling to minimize the number of CT scans and false positives and potential harms. That concludes my statement.
Thanks very much, Dr. Campos-Alford. Okay. We will now take a break for 10 minutes, and we will re-adjourn promptly at 9:50. I would like to reconvene and ask our public speakers to take their seats. Everyone has seats in the front row, and then, oh, over there. Okay. What is going on? Okay. Everyone has seats over there. And then what? Where's Art? So our first public speaker, and each speaker will have 4 minutes, and I'll set the timer, is Dr. Albert A. Rizzo. He's Medical Director of the EICU, Section Chief of Pulmonary and Critical Care Medicine at Christianic Care Health System, and past Chair of the National Board of Directors of the American Lung Association. Thank you, Dr. Rizzo.
Thank you. I have no conflict of interest to disclose. And as stated, I am a past chair of the National Board of Directors of the American Lung Association and speaking here on their behalf. I want to thank you for letting the American Lung Association share our views on this important topic. We strongly urge CMS to include low-dose CT screening among Medicare's covered services at a minimum for the high-risk groups identified by the U.S. Preventive Services Task Force. This coverage will give high-risk Medicare patients access to the only secondary prevention method currently available. The ALA asked the committee to consider some additional points. We urge CMS to be flexible and amenable to changes in coverage decisions when any new findings indicate appropriate expansion of these screenings and other high-risk populations, such as patients with reduced lung function, chronic obstructive pulmonary disease, patients with certain occupational exposures, and patients with a 30-year history who quit smoking more than 15 years previously. Both the American Lung Association and the American Cancer Society will be submitting recommendations regarding the additional risks in this population. American Lung Association requests the CMS put into place methods to ensure rapid progress toward achieving high standards of recommended care in the screening process, and this should include data collection such as patient demographics, smoking histories, comorbidities, and imaging technologies, as well as the creation of patient registries, the creation of and performance of medical audits, and provision of incentives and accreditation of screening programs. The Lung Association strongly recommends that CMS require institutions to collect data on all patients undergoing lung cancer screening, including those that are not currently considered high risk by the USPSTF task force. Evidence development in other populations identified at risk by the National Comprehensive Cancer Network, such as those with family history, high-risk occupational exposures, and longer quitting histories than 15 years, will be critical in expanding further coverage for screening and minimizing barriers so that more appropriate people are screened and further unnecessary lung cancer deaths are prevented. American Lung Association urges the committee to require smoking cessation treatment be offered to any patient screened for lung cancer. Smoking is the most important avoidable risk factor for lung cancer and accounting for approximately 85% of all the cases. Tobacco avoidance is still the primary way to prevent lung cancer, and lung cancer screening offers an ideal opportunity for an educational moment, and cessation services should be provided to those at highest risk of lung cancer. Finally, I want to try to put a face, or at least a voice, on our recommendations by sharing a personal story from one of our volunteers, Christine. Christine's mother, Donna, would have met the USPS task force definition for being at high risk and considered worthy of CT screening had the recommendations been in effect even a year ago. This is her statement. My mother, Donna, was diagnosed with lung cancer on August 23, 2013, and died on October 1st, only 5.5 weeks later. I'm grateful she did not suffer a long time in pain, but for my dad, my sister, and I, there is a hole in our hearts and lives that will never heal. I know that most people will take up a cause when affected by a preventable personal tragedy in order to try to keep others from experiencing the same thing. I never considered myself a cause-type person, but I knew that my mom's lung cancer could have been detected so much earlier if she could have been screened with CT scans. Since lung cancer has few or no symptoms early on, I am convinced that the low-dose CT screening will save lives by detecting lung cancer much earlier. I urge Medicare to include the screening for high-risk patients so that others might have a fighting chance, something my mother didn't have. So on behalf of the American Lung Association, on behalf of Christina, and on behalf of all the lives that could be saved with lung cancer screening, I thank you for listening.
The next speaker is, if I apologize if I don't pronounce it right, Albert Hu from from St. Joe's Hospital and Medical Center, and he's a director of minimal invasive robotic program and surgery at St. Joe's.
I'd like to thank the panel for the opportunity to present our 2.5-year lung cancer screening experience in an area endemic for valley fever and pulmonary nodules. I have no financial relationships to disclose. Our program was started in September of 2011 and is based out of St. Joseph's Hospital and Medical Center, which is a 500-bed community-based hospital in Phoenix, Arizona. There are 5 key aspects to our program. First, we do a detailed intake questionnaire on all our patients, focusing on their lung cancer and heart disease risks. In addition, we make sure that the patients have an established primary care physician who we can communicate the results to. The patients also have to meet strict high-risk entry criteria to qualify for our program. Second, we have multiple screening locations throughout the valley that all use the same low-dose CT protocol to minimize radiation exposure. The studies are read by only 3 dedicated fellowship-trained thoracic radiologists who are involved in our program. Third, every positive finding is reviewed in a multidisciplinary meeting once a week. Our team consists of pulmonologists, radiologists, oncologists, thoracic surgeons, infectious disease specialists, cardiologists, and primary care physicians. At this meeting, each patient is discussed in detail, and individualized recommendations are given based on NCCN guidelines, taking into account the patient's risk factors and radiological characteristics of the nodules. Non-pulmonary findings are also discussed at this meeting. Fourth, results, along with recommendations, are promptly communicated to the patient and their primary care doctor. This communication has been aided by electronic medical records and is very well received by the primary care physicians. The patient is also given a one-on-one physician consultation to go over the results and work on smoking cessation and other lifestyle modifications. Fifth, we can have an active database that all patients are entered in and the data is reviewed regularly. For those not familiar with valley fever, 2/3 of all valley fever cases in the world occur in the corridor between Phoenix and Tucson. Valley fever is caused by fungus in the soil. The spores become airborne and are breathed in by people's lungs. This often leads to localized infection and pulmonary nodules. Because our program is located in an area endemic for valley fever, we expect our pulmonary nodule rate to be higher than other areas of the country. This raises a question: can a lung cancer screening program be successful in an area with a large number of pulmonary nodules that are not going to be lung cancer? In our 2.5-year experience, we reviewed 512 patients. Of these, 329 have been scanned and met our high-risk criteria. As expected, we had a higher pulmonary nodule rate than the National Lung Cancer Screening Trial. 50% of the scans had a pulmonary nodule compared to just 27% in the NSLT. However, we were able to keep our invasive testing and imaging rates low with a 2% PET scan rate and 2% CT-guided biopsy rate. The NSLT rate for the PET scan was 10% and 2% for biopsy. In our 329 patients, we found 3 lung cancers, a breast cancer, and 1 patient with lymphoma. In addition, 20% of the patients scanned had bad COPD or pulmonary fibrosis, and 30% had moderate to severe coronary calcifications. Smoking is a risk factor for both these conditions and their progression. We conducted a survey of the first 100 patients 1 year after their initial screening. 79% of the patients either quit smoking or cut down on their smoking. In addition, due to our counseling, 35% improved their diet and 33% improved their exercise. Counseling after lung cancer screening is a very teachable moment that can result in important lifestyle changes in these patients. The key to keeping our invasive testing rate down is that we look at each patient individually and have information on their risk factors and behaviors based on their intake questionnaire. We take the radiological findings and incorporate them with information based on the patient's intake questionnaire and risks. In conclusion, I think, to answer the question, can a lung cancer screening be successful in an area with a large number of pulmonary nodules that are not lung cancer? I think the answer that our program has shown is absolutely. Lung cancer screening can be conducted in a fiscally responsible manner, minimizing risks, unnecessary testing, and patient harm, while saving lives and resulting in important lifestyle changes in a high-risk population. Thank you for the opportunity to speak today.
Thank you, Dr. Koo. Our next speaker is Dr. Michael McNitt-Gray, who is the chair of the CT Subcommittee, AAPM, and a professor at the David Geffen School of Medicine, UCLA.
Thank you. I appreciate the opportunity to come and present to you today. I should also mention that I'm was a member of the National Lung Screening Trial Physics Subcommittee. Here are my disclosures, institutional and grant support from Siemens. AAPM has no disclosures here. hear some information about the APM. But my remarks will be primarily directed towards question 2 about the harms of lung cancer screening, which will be minimized from the low-dose CT itself. The target value that's been stated is 1.5 millisieverts. That's just a little above what the value was for the average whole body effective dose for participants in the National Lung Screening Trial. One of the ways that we helped keep that dose low was develop a protocol chart, which I'll talk about in a second, and keep specifically the average scanner output, which is reported on the scanner, of that CTDI vol value less than 2.9 milligram. Sorry. The protocol chart was developed in 2002. It was published in 2006. It developed technical settings across 14 different scanners from 4 major manufacturers at the time, again, specifically targeting different technical factors, including the CTDI vol, which was less than 3.0 milligray for a standard-sized participant, with one exception, of one particular scanner. That technique chart was developed in 2002. Again, the techniques were low dose, considered low dose at that time. In the intervening dozen years, all scanners have technologies that allow significantly reduced dose. Automatic exposure control methods, advanced reconstruction methods, advanced detectors. These will all contribute substantially to the dose reduction beyond the 1.5 millisieverts. That protocol chart developed in 2002 did not require any specialized equipment. These were regular CT scanners above a certain slice level, that was all. And this can be achieved with the majority of scanners purchased in the last 15 years. So this 1.5 millisievert with no advances in technology is readily achievable and does not require specialized equipment. But with using current technology, we can get those values much, much lower, significantly lower than the 1.5. Some other activities that will help reinforce keeping the doses low during these scans. The American College of Radiology has developed a practice guideline which will state specifically, make recommendations about technology level and about this dose level, the CTDI vol value. Again, that's a value reported on the scanner itself, so it can be tracked. The designated lung cancer screening programs from the ACR will actually make these requirements. It'll require a minimum CT technology level and require that the CTDI vol be less than or equal to 3 milligram, again, keeping the dose low to participants. My professional society, the American Association of Physicists in Medicine, has developed, in collaboration with the manufacturers, some CT scanner protocols. These have been made publicly available for routine scans, such as routine head, routine chest, routine abdomen. This group has made them publicly available outside of its membership and has publicized them quite widely and disseminated them. They are currently working on a low-dose lung cancer screening protocol, which the first version will be made available next month. These charts look very detailed. They have a lot of information in them. They are specific to scanners and specific makes and models, but they are targeted to a specific audience who's going to use this. This is not the lung cancer screening protocol, but it will look just like this, but with lower techniques and thinner sliced images. So the 1.5 millisievert effective dose, I wanted to put that in some context, that the average whole body effective dose in the United States from natural sources is 3 millisieverts, twice that number. Radiation workers such as myself and radiologists and radiation technologists are allowed up to 50 millisieverts per year over a 40-year working life. One other comment that you should know is that the radiation risks, the actual risk of detriment, decreases with age and decreases substantially even into the 60s and 70s and 80s. In conclusion, there is an outstanding chance of achieving a 1.5 millisievert dose in the participants in any screening program, and there's an excellent to outstanding chance that doses will be substantially lower due to advancing technologies. The vast majority of scanners now can meet these goals, and the ACR and APM efforts will help require or reinforce these low-dose techniques. Again, just to put these in context, this low dose, the 1.5 millisievert, is half of what we get average person in the United States each year.
Finish.
Okay. And 3% of what radiologists and radiation workers are allowed, and they decrease substantially with age. Thank you.
Thank you.
Next is Claudia Henschke from Icahn School of Medicine in Mount Sinai in New York. Please disclose any conflicts you have if you don't have a slide about that.
Claudia Henschke, my disclosures are given here as well as in what I submitted. So thank you for the opportunity to talk to you. and to answer your questions. We've had a registry for more than 20 years, and it can be used to address some of your concerns. It started out as 2 centers in New York City, screening 60-year-olds at high risk, smokers, and expanded to 12 other sites in New York State with the same risk, and then to 73 sites around the world. We have jointly screened more than 66,000 participants at this time. The registry registers all screenings at participating institutions using a common protocol which is regularly updated. It has a web-based infrastructure that provides structured data forms for documentation of the imaging, biopsy, and treatment findings. The quality assurance process is incorporated in the web-based infrastructure, and we provide formalized training of participating radiologists. We will provide the infrastructure to the Registry for Excellence in Screening led by the Lung Cancer Alliance and its participating institutions within the framework of excellence in screening, and to the other societies listed here. We have used this approach, this registry, to look at how we can reduce the frequency of positive results and the diagnoses of lung cancers. As shown here, they can be markedly reduced by increasing the thresholds, and those thresholds have been adopted by others. We've answered Dr. Bach's comment in print saying it's the same for the NLST groups, but we also have a publication in press that looks at the NLST data and shows that the results are the same for the NLST population. On baseline, most of the people go on to the first annual repeat screening. Only those who have a nodule 6 millimeters and larger will have further workup, and typically that's another low-dose CT scan. The invasive findings are limited to some 2%. And on annual repeat, it's the same thing. Most of them are recommended to go to the next annual screening. So looking at the consequences of that in the U.S. population, looking at those 65 and older meeting the NLST smoking criteria, 13%, as shown in red, would have a positive result on the baseline screening and 9% on the annual repeat screening. And that would result in 80%, again shown in red on the right, to have a stage 1 lung cancer diagnosed. Pathology stage is a little lower, 73%. And that translates into a 15-year Kaplan-Meier cure rate of 72%. So really, that Medicare population, the results are very comparable for that population as for the 55 and older. We looked at the academic versus community setting and found there were no differences in the frequency of positive findings, in the frequency of stage 1, or in the estimated cure rates. So we think that ILCAP really is the largest ongoing registry, and it provides external validation of the NLST results in a real-world setting in both academic and community practices. This can save lives as long as it is made readily available to those at highest risk of lung cancer. Thank you.
Thank you. Our next speaker, thank you, Dr. Hinchke. Our next speaker is Ella Kazaruni, Professor and Director of the Division of Cardiothoracic Radiology and Vice Chair of Department of Radiology at the University of Michigan.
Thank you very much to the panel for allowing me to present today on behalf of the American College of Radiology. I have no relevant disclosures. The American College of Radiology represents more than 36,000 diagnostic radiologists, radiation oncologists, interventional radiologists, nuclear medicine physicians, and medical physicists who are all critical to the quality and safety and dissemination of lung cancer screening practice today. For over 3/4 of a century, the ACR has devoted its resources to making imaging safe, effective, and accessible to those who need it. The ACR has a long track record of activities in quality and safety, with CT accreditation programs going back into the 80s, many practice guidelines and standards that have been readily adopted and used by radiologists today in practice, and appropriateness criteria which guide our use of imaging. We also have extensive experience in registries when needed to answer questions for which there is lacking evidence. I will leave this on as my last slide, with additional slides provided as details for the panel to consider about these activities. This week at the American College of Radiology's annual meeting, we approved a new practice guideline for the performance and interpretation of lung cancer screening CT. It addresses who should be screened, when they should be screened, and how they should be screened relative to quality and safety, low radiation exposure, and the frequency of testing. Importantly, we also released version 1 of LungRads. This is based on the 20-year experience of the ACR with BI-RADS, which is now in its 6th edition. Radiologists know how to use and have widely adopted BI-RADS in clinical practice. LungRads is the equivalent for lung cancer screening. If LungRads is adopted, and we expect our radiology practitioners will take this up widely, they have been calling for it and asking for it from the ACR, it will reduce the false positive rate from the 27% seen in NLST to only 10%. This will substantially reduce downstream diagnostic testing and make lung cancer screening even more cost-effective than in what has been shown today. The ACR endorses the USPSTF Grade B recommendation for lung cancer screening and believes it's the right thing to do, that there is definitive evidence that lung cancer screening with low-dose CT can be done safely, with little harm, low radiation exposure, and is the right thing to reduce mortality for this cancer that kills more men and women than any other cancer in the U.S. today. Under our CT accreditation program, we have also released a new ACR-designated lung cancer screening center program designation. This specifically takes into account the training of radiologists to interpret lung cancer screening CT and the lower radiation CT techniques which are required to do this safely in practice. We are developing our appropriateness criteria modeled after the USPSTF and NCCN recommendations, and are aggressively developing educational programs and campaigns both for radiologists and providers, as well as the public and patient awareness, to make sure that lung cancer screening is done in those who need it, and it is done well with an attention to safety. Again, I'd like to thank the panel for allowing me to present today on behalf of the American College of Radiology. Our practitioners are ready and willing and able to perform lung cancer screening CT safely. Many of them, as you've heard already today and will continue to hear, are already doing this in practice. They're doing it safely. They're doing it using their versions of structured reporting, which we are now bringing to bear in a standardized manner for all of them to follow in a consistent manner. And we believe this will move forward lung cancer screening CT for the patients who need it with safety and quality and to do the right thing. Thank you very much.
Next is Claudia McKee, who is the chair of Andrea McKee, I'm sorry, radiation oncology, and there would be a team of people talking for 4 minutes.
No, I'll explain. Thank you for this opportunity to speak with you today on our experience with CT lung screening. My name is Dr. Andrea McKee. I'm the chair of radiation oncology, but I am here today with Dr. Carla Lamb, who is of our pulmonary and critical care department, as well as Dr. Robert Faust of internal medicine, so that they may speak to any questions that you might have regarding our team-specific role in our CT lung screening process, but I'll be doing the speaking. We have no disclosures. Leahy Hospital and Medical Center is a multi-specialty group practice and part of the parent accountable care organization Leahy Health. CT lung screening is viewed as an integral tool in the management of our high-risk population. In January of 2012, the hospital tasked a multidisciplinary team of physician leaders and administrators to develop a low-cost, high-efficiency, value-based delivery system to offer CT lung screening as a community benefit such that all eligible high-risk patients could access this proven life-saving test regardless of socioeconomic status. To achieve cost-effective decentralized screening, our program requires the primary care team to partner with radiology to identify, inform, and follow all eligible patients. Overcoming identified obstacles to CT lung screening required special focus in two important domains: a continuing education campaign run through our Cancer Services Department and the development of infrastructure, including a structured reporting tool, LungRads, and database to track findings in radiology. We follow the NCCN guidelines to define our high-risk population. Listed here are the secondary risk factors for NCCN Group 2. They comprise 25% of our patients in clinical practice. Ordering sheets with clear CT lung screening entry criteria are provided to primary care offices to facilitate appropriate referrals into the program. In addition, high candidacy is assessed centrally in radiology through trained CT schedulers and program navigators. 20 to 30 patients enter our program each week. More than 65% are referred directly through their primary care physician. The program has screened over 2,100 individual patients and performed more than 3,000 screening exams. The program currently manages an average of 60 patients per week. A 4-page FAQ document is provided to all patients, and a physician order is required for a patient to enter our program. All scans are interpreted by a trained radiologist, but not a thoracic radiologist. Our radiologists provide general radiology services at Lahey. 2/3 of the time, there are no actionable findings. 1/3 of patients will have a finding for which an evidence-based recommendation is linked to the structured LungRads report. This slide is perhaps the most important one because it demonstrates that through use of structured reporting, we are able to triage patients into risk categories so that only those patients with suspicious findings, those larger lesions or growing nodules, for example, are referred to care escalation, which in our center is defined as pulmonary consultation. The vast majority of patients, 96% of them, are co-managed by primary care and radiology, thus reducing the risk for unnecessary testing in those unlikely to have lung cancer. This is an important and critical quality and safety feature of the LungRads system. Of the small percentage of patients referred to specialty care, less than half of them undergo an invasive procedure. The rate of intervention in false positives in our program is 2%, comparing favorably to the NLST. We track all quality metrics and benchmark against NLST benchmarks. Every other month, these program statistics are reported to our multidisciplinary steering committee. Smoking cessation is integrated across the care continuum with the opportunity to engage in teachable moments and help move patients through the various stages of quit readiness.
It's time to wrap up.
Okay. Primary care trust and reassurance is essential to a decentralized, value-based program. It is important for primary care to trust the system, which they do because they are familiar with BI-RADS and therefore very easily adapt LungRads, as do the radiologists. We have data regarding NCC Group 2 statistics, which I will skip in the interest of time. However, I will make the point that they are remarkably similar to NCCN Group 1, with the only difference being there are more former smokers in Group 2 than in Group 1, and there is a longer average age of quit in Group 2. I will end by saying the materials that we have developed in our program are made available to anyone who wants to access them. Over 500 sites across the country have accessed and downloaded our information. In my experience, community centers are highly motivated to understand the important elements necessary to develop best practice programs that will allow them to bring about the unprecedented benefit of CT lung screening to their high-risk populations. Thank you.
Thank you, Dr. McKee. Our next speaker is Dr. Douglas Wood, Professor and Chief of the Division of Cardiothoracic Surgery and Vice Chair of the Department of Surgery at the University of Washington.
Thank you. And my disclosures are on my title slide. I think most notably, I'm the chair of the NCCN Lung Cancer Screening Panel. And I'm going to completely redirect a portion of my comments in order to correct areas of misunderstanding of lung cancer screening presented by Dr. Campos and leading to a disparate and confusing recommendations from the AAFP that are different than every other guideline on lung cancer screening. Dr. Campos assumed highly protocolized nodule management within the NLST as a reason that the results would not be representative of real-world practice. This is a completely incorrect assumption, as noted by several other speakers today. Yet, in fact, a disciplined algorithm for nodule management has the opportunity to further lower the unintended harms of downstream diagnostic testing. Second, Dr. Campos presented the assumption that longer screening duration increases the false positive rate to near 100%. However, as presented by Dr. Pinsky and confirmed by all of the radiologists in this room, the opposite is what's true. Further follow-up scans result in fewer and fewer false positives, not more. It is disturbing that a prominent position of the AAFP is undermined by these incorrect assumptions. Thoracic surgeons have the expertise to address the potential harms of screening, as they are predominantly related to follow-up testings, biopsies, and surgical resection. Surgeons have been very systematic and thoughtful in evaluating how many patients have surgery and their outcomes. This recently published surgical paper looks at the surgical experience from nearly 32,000 patients in the ILCAP lung cancer screening program. 1.6% underwent surgery, and 89% of those had lung cancer, with a remarkable 84% 15-year survival compared to a national rate of a 16% 5-year survival for lung cancer. Less than 2 per 1,000 patients had surgery without having cancer, and nearly all of those were minimal lung resections that would not be expected to have significant adverse long-term consequences. The well-established method of reducing the harm of screening is the adoption and disciplined adherence to an evidence-based algorithm for patient management. The NCCN guidelines not only make recommendations about the population of patients to be screened, but also provide systematic guidance for virtually every clinical scenario arising from lung cancer screening. And NCCN guidelines have annual updates as new knowledge becomes available. For example, the most recent version increased the size defining an abnormal lung nodule in response to important work published by Dr. Henschke and colleagues, with the goal that this will further reduce testing without an impact on the ability to detect early lung cancers. NCCN guidelines developed by a wide breadth of experts in the field provide guidance that can allow even relatively inexperienced programs safe and evidence-based management algorithms to help them minimize harms of screening while achieving the maximum access and availability for lung cancer screening to patients. NCCN also outlines the risks and benefits of screening, and in this year's update we'll be adding language supporting shared decision-making between patients and their doctors, so that patients can be provided the best possible information to inform their own choices on whether to engage in lung cancer screening. Thank you.
Next is Dr. Charles White from Society of Thoracic Radiology, who was the past president of Society of Thoracic Radiology. Now he's from University of Maryland.
Okay. Well, again, I want to thank the panel for allowing me to speak. And as past president of STR, I wanted to tell you, first of all, that I have no disclosures. And second, to give you a little bit of a rundown of what the Society of Thoracic Radiology is. It's a society that's now closing in on 35 years old. It's the largest society of thoracic imagers in the United States and throughout the world, with over 750 members with wide representation in the United States, residing in over 45 states, and also has both wide representation in the academic and in the community setting. The mission of the STR is to promote excellence in cardiothoracic imaging and improve patient care through research and, importantly, through education as well. Improving patient care, I'll start with that and talk about optimizing image quality. And Dr. McGray mentioned earlier, this is also part of our mission to optimize image quality, decrease radiation dose, and in addition to that, to provide best practice education to radiologists and other practitioners. There's also a commitment to thoracic imaging research and in particular to lung cancer screening. To give you examples of the Society of Thoracic Radiologists' education and research efforts, there's an annual meeting of which the largest component is really a review course for the practitioner. There's also a website which is available with case of the day features and multiple downloadable lectures, including educational lectures on lung cancer screening, and importantly for this panel, cutting-edge research including lung cancer screening with low-dose CT, for which most of the members most of the involved PIs were members of the STR, including everybody here on the speakers list, to my knowledge, is a member of the STR. ILCAP as well consists of large numbers of STR members. Other STR member efforts that are going on include a joint ACR-STR lung cancer screening training course that is being developed right now to be presented at the ACR Educational Center, and as well a day-long symposium categorical course that will be presented at the very least at the next STR meeting. So this is an ongoing and intense effort. We would like to recommend broad national coverage for lung cancer screening with low-dose CT based on the NLST results and the USPSTF recommendations, and also CED for other groups at high risk that do not fall specifically within the above categories with data registry enrollment. Thank you very much.
Thank you. Thanks, Dr. White. And next, we have Dr. Richard Frank, who is the Chief Medical Officer of Siemens Healthcare and Chair of the Medical Imaging, I'm guessing, Technology Alliance Coverage Committee.
Excuse me, I have an announcement. We are not allowed to take pictures or recordings, so please stop taking pictures and recording today's meeting. The meeting is being broadcast live via CMS, so if you would like to go back and see the meeting, you can do so. So again, please refrain from taking pictures, or we will have to have your cameras in your phones. I'm sorry, we will have to take your cell phones. Thank you.
Good morning. My name is Richard Frank. I'm the Chief Medical Officer at Siemens Healthcare, speaking today on behalf of MIDA, the Medical Imaging and Technology Alliance. MIDA is the leading trade association representing innovators of medical imaging, radiotherapy, and radiopharmaceuticals, and appreciates the opportunity to contribute to today's deliberations. MIDA and its members develop quality standards for medical imaging equipment, in particular for dose reduction. The reductions in exposure achieved over the last decade of innovation have dramatically improved the risk-benefit ratio in favor of annual cancer screening procedures. Last year's B recommendation by the USPSTF in favor of coverage for low-dose CT and lung cancer screening has been further validated by ongoing accumulation of clinical evidence of the safety, efficacy, and efficiency achievable by implementation of this life-saving screening procedure in the high-risk Medicare population in community settings. Early detection and accurate diagnosis in lung cancer enable early and appropriate therapeutic intervention with the prospect of a better outcome for the patient achieved at a lower cost to the healthcare system. The CT community has developed a set of quality standards. Participation in this initiative was broad, including notably the FDA, the American College of Radiology, and the American Association of Physicists in Medicine. MIDA member companies have incorporated these standards into product design to enable quality images at lower doses of radiation. Among these dose standards, the most relevant to today's deliberations is NEMA Standard XR29, also known as MIDA Smart Dose, which includes 4 components: DICOM structured reporting of radiation dose, pediatric and adult reference protocols for image acquisition, dose check, which is a set of alerts and alarms prior to scanning if the dose exceeds preset levels, and automatic exposure control. In compliance with those standards, here are 7 innovations the industry has implemented in the last few years. Given our time constraints today, I'll highlight only one of them. Automatic exposure control helps optimize the dose for each patient given the diagnostic task. This feature adjusts the exposure to use only what is needed to achieve the required image quality. This feature is now standard on CT systems. Innovations in CT detectors and image processing have maintained image quality while reducing exposure to levels well below ambient radiation. The dose necessary for lung cancer screening is a fraction of the dose for standard chest CT because it is inherently easier to characterize a nodule when it's surrounded by air. For comparison, this slide shows the average dose in the National Lung Screening Trial, or NLST, as compared to a typical dose for standard chest CT at the time of that trial. This difference has led to the use of the descriptor low-dose CT. Because ongoing innovation continues to reduce the dose emitted by CT, the phrase low-dose CT over time may refer to progressively lower doses. Indeed, the dose typical of the ongoing ILCAP registry already is half that in NLST, and much lower doses are being achieved already at institutions with the most modern hardware and software. The clinical benefits of these innovations are gained in practice through the efforts of professional societies. The dose registry maintained by the American College of Radiology has led to less variability in dose across the participating radiology departments and an overall reduction in average dose in clinical practice. Consistently low exposure in the community setting will further benefit from the widespread use of the standard acquisition protocol developed by the American Association of Physicists in Medicine. In summary, the USPSTF's favorable recommendation is substantiated by ongoing accumulation of clinical evidence for safety, efficacy, and efficiency being achieved already in community settings. Exposure in low-dose CT already is low, and ongoing reduction in exposure will result from innovations by technology companies, the ACR's dose registry, and the AAPM's acquisition protocol, tipping the risk-benefit ratio strongly in favor of screening for lung cancer on an annual basis. Early detection and accurate diagnosis in lung cancer enable early and appropriate intervention with the prospect of a better outcome for the patient, achieved at lower cost to the healthcare system. Thank you.
Next is Vicki Beckler, who is a lung cancer screening coordinator from WellStar Health System.
Great. Thank you. Thank you for allowing me to present today. I'm actually a nurse with WellStar, and I'm responsible for the largest community-based screening program in Georgia. And neither WellStar nor I have any financial conflicts of interest today. WellStar is a not-for-profit healthcare system located in Metro Atlanta. We are accredited as an integrated network cancer program by the Commission on Cancer. We have 5 hospitals, 4 health parks in 5 counties, and serve more than 1.4 million area residents. We have performed more than 3,000 lung cancer screening CT since 2008 and have more than 1,300 patients in our program. We were early participants in the ILCAP lung cancer screening trial, and we co-authored the National Framework for Excellence in Lung Cancer Screening and Continuum of Care. We monitor patient outcomes and track our data, and our biopsy rate is less than 3%, and actually 63% of our lung cancers through screening were detected at an early stage. This is 4 times the national average of only 15.4%. As followers of this document, all screening is performed through a dedicated program, through a multidisciplinary team of physicians, and despite what was presented earlier from the National Office of Family Physicians, our program was strongly supported and is strongly supported through an engaged partnership with our local family doctors. And nearly 1/2 of all of our patients report they were referred to our screening program as a result of a conversation with their local primary care doctor. Patients are assessed for eligibility using NCCN criteria and are required to sign a disclosure acknowledging risk. We screen at 10 medical imaging centers, all accredited by the American College of Radiology, and we use specific scanner protocols to ensure lowest possible radiation dose, which is approximately 1 millisievert. We follow a comprehensive process for image interpretation and management of lung nodules. Patients may elect to participate in outcomes research through our registry, which we're very proud of. Screening results are promptly communicated to the patient and the primary care provider. By following rigorous protocols as set forth in the framework, we minimize unnecessary cost, time, and potential harms associated with screening and isolation. The power of lung cancer screening is in early detection and saving lives in a cancer that is expensive to treat in the late stage and one of the most financially burdensome to not only Medicare but the entire healthcare system. What if 85% of those diagnosed were detected early versus late? The financial savings to Medicare alone from a stage shift in detection would be staggering. Do we really need another complicated systematic review or another expensive research study? The evidence is indisputable. Lung cancer screening saves lives. We embrace some of the concerns that were discussed or voiced earlier today. In fact, we all want the same thing, to ensure that lung cancer screening is conducted safely and responsibly with rigorous protocols to improve patient outcomes and reduce mortality. Every screening procedure has inherent risk. The real-life experience of our program, in contrast to the theoretical statistical analysis, demonstrates that the system of multidisciplinary care minimizes risk and maximizes benefit in lung cancer screening, even in a community-based program. These results can be replicated and performed safely in local hospitals and centers which deliver comprehensive, patient-centered cancer care across this country on a daily basis. As a matter of fact, more than 170 community hospitals already do so by following this framework. The NCI estimates that only 15% of cancer patients in the U.S. are diagnosed and treated at the nation's major academic cancer centers. The vast majority of these patients are treated in community hospitals near the communities in which they live. People deserve access to safe, affordable lung cancer screening and care close to home. Please do not impose unnecessary barriers to access. Please support the U.S. Preventive Services Task Force recommendation for lung cancer screening, and thank you for your time and consideration and opportunity to be here today.
Thank you. Next is Dr. Richard Wenzer, Chief Cancer Control Officer at the American Cancer Society.
Thank you. I appreciate the opportunity to be here. I'm here with wearing two hats because I also chaired our Lung Cancer Screening Guideline Committee while chair of the Department of Family and Community Medicine at Thomas Jefferson University. I then subsequently became Chief Cancer Control Officer at the American Cancer Society, so I'm representing both viewpoints. Other than chairing that guideline, I have no conflicts of any kind. It's thrilling to be able to say that the major cancer screening guideline groups have achieved a high level of consensus regarding guidelines. The ACS, the Task Force, NCCN, all recommend that lung cancer screening be provided to populations at high risk. You've heard the presentation of AAFP, but for those guideline groups who engage regularly in screening guidelines for cancer, there's a high level of consensus. There are some differences, and I will comment on those briefly. At this time, most of the U.S. organizations do endorse the NLST entry criteria for lung cancer screening. I think it's important that the panel understand that this is actually a relatively high bar for near-term absolute risk. And as has already been mentioned, I do believe we will be able to refine risk criteria over time to identify those who are at particularly high risk and perhaps those who are at lower risk. The USPSTF had one caveat that they actually withdrew eligibility once the individual was beyond 15 years post-smoking, smoking cessation, which was not the protocol used in NLST. Once you were eligible, you remained eligible, and that is what the ACS recommends. We did not comment, ACS, about the use of combination of risk factors and appreciate the opportunity to continue to look at risk and eligibility. Thus, ACS recommends that Medicare beneficiaries should be covered for annual lung cancer screening without copays or deductibles if they meet ACS criteria for age and smoking exposure. This recommendation also applies to surveillance exams following a positive finding on CT screening. The ACS has considered the recommendation of the task force to extend the screening age to 80 and can support coverage for otherwise healthy 80-year-olds who meet established criteria. And as mentioned, if we are going to expand eligibility, that we would support a coverage with evidence program. 3 final points. This trial, the NLST, was conducted with 3 annual CTs conducted in a 2-year period from 2002 to 2005. As you have heard repeatedly, it is very likely, virtually certain, that the ratio of benefits to harms has substantially improved since that time, and that additional benefit will actually be seen with annual screening rather than the 3 screens within a 2-year period, 0, 1 year, and 2 year. Second, the term, a phrase of 18% overdiagnosis was mentioned. That's using an extremely conservative and probably inappropriate way to measure overdiagnosis, which is the ratio found at the end of the screening period. To calculate overdiagnosis, these patients need to be followed 10 to 15 years, and it is virtually certain that the overdiagnosis rate is far lower than 18%. Finally, we have substantial evidence that's been presented that this program can be implemented with a high level of accuracy and safety in many settings around the nation. The best way to improve quality is to provide this service with accreditation, with the kinds of programs that we've seen, with quality monitoring, with incentive payment. That's the best way to improve quality while making this test available to all eligible individuals. Thank you very much.
The final scheduled speaker, not the final, I'm sorry. The next speaker is Jody Ruth Steinhardt, who is a coordinator at Maimonides Medical Center.
Good morning, and thank you for the opportunity to speak about the importance of Medicare coverage for lung cancer screening. I represent Maimonides Medical Center, a community-based hospital in Brooklyn, New York. We have no disclosures. Our comprehensive program brings together pulmonologists, radiologists, thoracic surgeons, nurse practitioners, and health educators for a full complement of services. Referrals come from a variety of sources, with the overwhelming majority being from physicians. All patients who come into the program are screened at intake for appropriateness using the National Lung Screening Trial criteria. On the day of a scheduled appointment, patients are met at the door, informed of the risks and benefits, escorted through the CT scan, and then contacted via phone and mail with results and follow-up as dictated by protocol. The primary care physician is an integral part of the team. Because we recognize that on a population basis, primary prevention is more effective than secondary prevention, we have also integrated a smoking cessation initiative into our screening program. Screening participants who are current smokers are strongly encouraged to quit and offered access to our smoking cessation programs. We use the American Lung Association Freedom from Smoking curriculum. Brooklyn has the highest population of older adults of all 5 boroughs of New York City. Our residents are ethnically diverse, with almost half of them having been born outside the United States. They are economically diverse as well, with many representing working-class families, some of whom are living at or below the poverty line. These groups have a high prevalence for smoking or past smoking and have an increased risk for developing lung cancer. We are all too aware of the cost in human lives due to lung cancer. Maimonides Medical Center has a Commission on Cancer designated cancer center where tremendous resources, both financial and otherwise, are spent trying to help patients with late-stage disease. Unfortunately, as this committee is aware, despite the best intentions in the most recent treatments, when the disease is diagnosed at a late stage, not only are these treatments often ineffective, but also use a disproportionate number of resources. The cost of treating late-stage lung cancer is astronomical. I think of a recent patient who happened to be a colleague who presented with stage 4 lung cancer. Despite aggressive, often debilitating treatment, 9 months later she passed away. The cost of her care was in the hundreds of thousands of dollars. The cost of a lung screening and finding malignancies early is far more cost-effective, to say nothing about the decreased physical and emotional toll on patients and their loved ones. Once the findings of the National Lung Screening Trial were published, showing a 20% decrease in lung cancer-specific mortality, we felt compelled to mobilize all of our resources to form a multidisciplinary lung cancer screening program. When our program started a year ago, it was a fee-for-service model where patients would pay $150 per scan. Since many could not afford this out-of-pocket expense, there was such backlash from the provider community, compelling us to find a funding source. I am happy to report that we were successful and that funding was made available for 200 scans, of which 106 have already been completed. Unfortunately, once these funds are exhausted, we may not have a way to provide the service at no or low cost to those at high risk of developing lung cancer. We project that the funds will be used in October of this year, just 5 short months from now. Since the beginning of the program, several patients have reported back to us that they have stopped smoking because of their experience going through the screening process. We are aware of the theoretical criticism that low-dose CT screening programs may cause unnecessary anxiety and unnecessary procedures. We also know that some say that implementing the rigorous standards outside of the context of a research study might be challenging. We are here today to enthusiastically say this is not the case. We have set up safeguards and criteria to determine who to screen, how to screen, and how to direct follow-up results of the low-dose CT scans based on published criteria. We know that there is a great need for lung cancer screenings from the number of people who have already come through our doors, and considering the increasing older adult population and the increased risk of lung cancer with age, it is imperative that screening for lung cancer become a covered benefit under Medicare. Thank you.
Thank you. Our next speaker is Dr. Dan Raz, who is from the Division of Thoracic Surgery and Director of the Tobacco Exposure Program and Co-Director of the Lung Cancer and Thoracic Oncology Program at the City of Hope.
Thank you. This is my disclosures. I wanted to share with you the development of our lung cancer screening program at City of Hope, where we implemented expanding use of meaningful use criteria to identify patients eligible for lung cancer screening as well as tobacco cessation. At our institution, we have an integrated lung cancer screening and tobacco cessation program that is led by an advanced practice nurse who's also a licensed tobacco cessation expert. We use NCCN lung cancer screening eligibility criteria, and we do not use an absolute upper age limit, nor do we exclude patients with severe COPD from screening. This is because these are 2 of the highest risk groups for lung cancer, and safe and effective treatment options exist for these patient populations. We currently use the NCCN lung nodule management protocol, and as we have no primary care affiliation, we expanded upon the CMS meaningful use tobacco questions and developed what we call the tobacco screen to identify patients who are eligible for lung cancer screening as well as for tobacco cessation. This screen was administered every 6 months for ambulatory care patients and recorded directly into the electronic health record, and was well received by the clinic staff. In our initial experience, reports were generated and patients were contacted by the program nurse to discuss screening. We're now implementing automated alerts to physicians so they may electronically refer patients who are eligible to the program for consultation. During the first 7 months of implementation, we identified 420 patients who were eligible. Unfortunately, 110 patients who were willing to pay the out-of-pocket expense enrolled in our screening program. And in addition, more than 40% of these patients underwent tobacco cessation counseling. While the incident scans had a 32% rate of detected nodules, only 3 patients, or 2.6%, underwent a biopsy. All of these were transthoracic needle biopsies, and all 3 of these patients had stage 1 non-small cell lung cancer. In other words, no patient without lung cancer underwent invasive testing, and that remains true still in our screening experience. All 3 patients with screen-detected lung cancer, the first 3 patients actually were treated with stereotactic body radiation therapy due to severe COPD and use of home oxygen or other patient factors. SBRT is a low-risk curative treatment option for patients who are at high risk for surgery and is considered standard of care for this population with stage 1 non-small cell lung cancer smaller than 4 centimeters. The efficacy of SBRT is well described in stage 1 lung cancer with local control rates of approximately 90% for cancer smaller than 3 centimeters. In conclusion, augmenting meaningful use tobacco questions is a feasible method of identifying patients eligible for both lung cancer screening as well as tobacco cessation, and it can be implemented by practices using electronic health records. Automated alerts to primary care physicians would be the most efficient method of implementing this, and in our and other centers' experience, lung cancer screening is safe, and it results in very few diagnostic procedures in patients who do not have a lung cancer when a nodule management protocol is followed. We and others have evolved in our management of nodules based on and since the data that Dr. Bach presented to minimize invasive procedures.
It's time to wrap up.
Okay. I just want to make clear that a positive scan does not mean a thoracotomy. We have minimally invasive methods of detecting lung cancer and of treating lung cancer, especially in patients with advanced age, where minimally invasive lobectomies and lung resections can be performed with mortality rates of 1 to 2%, and sublobar resections of less than 1%. And SBRT is associated with very low morbidity and excellent outcome for patients with limited lung function or otherwise who are at high risk for surgical resection. Thank you.
Thank you, Dr. Oz.
Next, we probably have one speaker or two sharing 4 minutes. Francine Jacobson and Michael Jacklich from American Association of Thoracic Surgery. I mean, they're from Brigham Women's Hospital, but representing the society.
We stand here together. I am Dr. Francine Jacobson, a thoracic radiologist, here with Dr. Michael Jacklich, a thoracic surgeon, in our capacity as co-chairs of the Lung Cancer Screening and Surveillance Task Force of the American Association for Thoracic Surgery, to convey our specific recommendations for lung cancer screening. We have no financial disclosures to make. Relative to the National Lung Screening Trial, it is proper for me to disclose that I was the site PI for Brigham and Women's Hospital as a participating site. Following the NLST, we reopened our program for clinical screening using criteria based on NLST and have continued to move that criteria in accordance with best recommendations, including the United States Preventive Services Task Force. We do take exception to what we call the quit rule about 15 years, and we remind the panelists that the entry criteria for the NLST specifically excluded those with a previous lung cancer.
The AATS specifically recommends annual screening beyond the limited entry criteria of the NLST trial to include Americans up to the age of 79 if they have preserved functional status. There are several justifications for screening through age 79. First of all, half of all the lung cancer victims are over the age of 74 years. Secondly, America is maturing and is expected to continue to mature with an average life expectancy of 78.6 years. The risk of developing lung cancer is dependent upon age, and Americans between the ages of 74 and 79 years have a disproportionate benefit from lung cancer screening. This observation was specifically confirmed by mathematical modeling by the USPSTF and published as an addendum to their December 2013 public statement. The USPSTF recommended screening to age 80. The peak incidence occurs in men over the age of 75 years and between the ages of 71 and 80 years in women. Furthermore, risk in smoking men and women exponentially increases as a function of age. Lung cancer screening must include Americans between the ages of 74 and 80, or the most vulnerable group will be denied the benefit of this detection. Since the elderly population has a higher rate of the disease, we are confident that the NLST trial would have been more significant if they had not been excluded from participation in that trial. We remind the panel that previous lung cancer victims were specifically excluded from the NLST trial due to the recognition that they have a higher risk of new lung cancer compared to the general population. After 5 years, they are considered cured of the initial lung cancer. This highest risk vulnerable population of over 400,000 lung cancer survivors, including some never smokers, and in particular, female never smokers, needs to be covered by low-dose CT scan screening. We appeal to, I'm sorry.
No, don't be sorry. We appeal to you to drop the quit rule. It has unintended consequences illustrated in the following example. 2 individuals, perhaps a couple, enter a lung cancer screening program at age 55 and both enroll in a smoking cessation program. One is able to quit, but one is not. At age 70, the individual with the successful smoking cessation experience is no longer covered by the quit rule. just as she is about to enter the age associated with greatest risk.
It's
time to wrap up.
The continued smoker, however, still benefits from screening because he continues to smoke. The general public will see this as unfair and discouraging to smoking cessation.
We have absorbed into the handout another slide that shows how we use the modeling criteria and things that can be done through risk assessment to move forward. And we would like to thank the panel for the opportunity to present the logic behind the AATS recommendations. We owe a debt to smokers who have provided the data to demonstrate the ability of early detection to change the natural history of lung cancer, and look forward to gathering the data to refine the benefit. Thank you very much.
Thank you.
Thank you. And our next speaker is Bruce Pyenson, who's Principal and Consulting Actuary at Milliman Incorporated.
Good morning. I am a fellow of the Society of Actuaries and member of the American Academy of Actuaries. And for the past 27 years, I've been employed by Milliman, a large actuarial consulting firm. I'm here as a private citizen. My employer, Milliman, consults to the majority of insurance companies in the United States and probably the world, as well as companies that have interests, diverse interests, including interests in manufacturing and scans. I'm one of the few non-clinicians in the room, but I'm following in the footsteps of actuaries who early on, perhaps a century ago, recognized the connection between tobacco and lung cancer, and also developed the survival models that are used today to measure survival in cancer. Actuaries' work includes measuring and protecting the solvency of insurance organizations, including Medicare, as well as coming up with the costs and financial forecasts. I've published several articles on the costs and consequences and mortality of lung cancer and lung cancer screening, and I'm going to give you some information today from very recent work that was funded by the Early Detection and Treatment Research Foundation, specifically on the Medicare population. I'm going to be talking about the cost and the cost benefit of screening eligible Medicare enrolled smokers and ex-smokers aged 55 to 79 using low-dose CT scan and follow-up protocols that have been developed by clinicians. The results I'm going to present are based on detailed models that are really deterministic actuarial models that combine life tables, decision trees, incidence rates, cancer stages, stage shifts, and treatment costs. On the cost of lung cancer screening for Medicare, my estimate is the cost is $1 per member per month, and that assumes about a 50% take-up rate of the approximately 4 million Medicare eligibles who would be beneficiaries who would be eligible. The total cost would be about $600 million, or approximately 0.1% of Medicare annual spending. We assume, based on the literature, that about 9% of Medicare beneficiaries would meet criteria for screening, and the $1 PMPM is based on assuming that about half of them would get involved. That's probably a high estimate, so the $1 per member per month is probably too high for a number of years. We assume that this is based on an annual screening and follow-up for 5 millimeter diameter nodules, but that would go down if the threshold were increased. Now, in our pricing of that $1 PMPM, we recognize that there would be no cost sharing for the initial CT scan, but follow-up CTs and follow-up biopsies would have typical beneficiary cost sharing, and these are 2014 dollars and based on 2014 schedules.
It's time to wrap up.
The basic other finding is that the dollars per life year saved is in the $20,000 to $25,000 range, which compares very favorably with other forms of cancer screening. So just in conclusion, I've looked at a lot of things. This is one of the best value population interventions I've seen, and I think CMS actuaries with their data would come to the same conclusion. Thank you.
Now I get to correct my mistake. So the final speaker today would be Dr. James Mulshine, who is a professor of internal medicine and who is the Associate Provost for Research and Vice President for Research at Rush University.
Yes, thank you very much. It's a privilege to be here. It's an incredibly important topic. I have no relevant disclosures. I have been heavily involved in lung cancer research for the last 30 plus years, 25 of which were at the NCI, where I had the privilege of working with a number of people here, directors of the Institute, in launching what wound up being the NLST. And it's incredibly gratifying to hear the evidence that is being shared with you today. I would just like to highlight a few things. In terms of lung cancer screening, we've already heard from Dr. Pinsky that this is very special. This is the most dominant lethal cancer in our world and in our nation. And it's one of the few opportunities through cancer screening that we have. In fact, it's probably unique in that it will potentially result in an overall all-cause mortality benefit. That is quite remarkable and needs to be thought about very, very carefully, because this is a population-based tool that actually can have traction in the war on cancer in a way that has eluded us in the past. We've heard an incredible amount of information about generalizability, and in fact, the key aspect of that is the generalizability information has been delivered with a very, very strong focus on discipline in terms of mitigating harms and cost and wear and tear on the target population. We've heard some information about concerns about the generalizability, the mortality reduction benefit of this service. And I would ask you to please go back to the U.S. Preventive Services analysis, because they dealt with this in a very comprehensive way. They pointed out, already shown in a table, that the two trials that no mortality benefit was demonstrated were the result of two small trials with essentially 10% of the accrual to those trials as we saw to the NLST. They had a much smaller duration of follow-up, and they were in low-risk populations. So the number of events was quite suspect relative to any kind of power calculation, such that it's really an inappropriate comparison, and they deal with it very politely in that analysis, and I'd encourage you to look at that again. And similarly, that analysis was very useful in looking at other issues in a much more comprehensive way than we've heard today about issues like quality of life and other things, where they surveyed very comprehensively the existing literature, and they found, in fact, there was no significant evidence of harm. The issue of overdiagnosis, Dr. Wender touched upon it, and it is critical. And the 18% number is, in fact, probably an overestimate, and one of the key reasons for this is because in that paper that was published on that subject that came up also with an 18% number, they included the management of bronchoalveolar carcinoma, which is a very benign acting form of carcinoma, which has been subsequently reclassified by the International Association for the Study of Lung Cancer to be part of a non-invasive management, i.e., it's not a disease that is recommended for operation. And if you, in fact, follow contemporary guidelines, as the thoracic surgery societies in our country do, and NCCN guidelines reflect, You do not operate on that, and you eliminate the single largest contribution to overdiagnosis in that calculation.
It's time to wrap up.
The final thing I would just say is that lung cancer, 85 to 90%, is a disease of smoking. Smoking is a habit which tobacco companies have preyed on our youth and have resulted in addiction of a large number of our population. Surgeon General has spoken about this in great detail. And we unfortunately know that the ravages of smoking are principally visited upon populations that have less economic resources, less educational background, higher educational background, and it's particularly vulnerable. And so creating barriers to access to these most critical populations for lung cancer risk is from a public health perspective, extremely disconcerting, and I would ask you to think about that very carefully in your deliberations, as I'm sure you will. I'll stop there.
Thank you, Dr. Morgenstern. I want to thank all of our presenters. We have 4 non-scheduled speakers who have all signed up. They will have 1 minute each, so you don't use your minute going to the podium. We'll ask you to speak from the microphone, and please remember to disclose any conflicts of interest or state that you have no conflicts before you start. Thank you. And our first speaker, is Andrea Burundi-Kitts.
Thank you. I'm a retired aerospace engineer, lung cancer advocate, and an MPH student. I do own mutual funds, and last week I signed a consulting agreement with Leahy Hospital Medical Center to provide patient-centered input into their lung cancer research studies. I lost my husband, Dan, to lung cancer in April last year. Dan had many of the risk factors. At the time of his diagnosis, he was 69 years old, an 80-pack year smoking history, quit 11 years prior, had COPD, and his sister died of lung cancer at age 62. In January of 2011, I talked to Dan's primary care physician about screening for lung cancer using low-dose CAT scans. His physician had not heard about the National Lung Screening Trial results, did not recommend the test, and my husband did not want to pursue it because Medicare did not cover the test. In October of 2011, Dan was diagnosed with stage 4 non-small cell lung cancer, and 18 months later, at 10:21 a.m. on April 12, 2013, he died in my arms. Lung cancer screening was too late for my husband, but it's not too late for those yet to come. Thank you.
Next is Christine Berg. Thank you.
Good morning, and thank you. I'm Dr. Christine Berg. I'm currently an adjunct professor of radiation oncology at Johns Hopkins. I was formerly the head of the National Lung Screening Trial at the National Cancer Institute. My conflict of interest is that my husband owns some General Electric stock. I have 2 issues that I wish to discuss. One, the mortality benefit from low-dose CT that we reported in our primary outcome paper was 20%. We had some dilution with follow-up or with lung cancer emerging after screening ended. So it's, as Dr. Pinsky reported this morning, with additional follow-up, it fell to 16%, and in my opinion, that's a result of dilution. One sentence in our paper that was presented this morning, I would, as the corresponding author, I would like to say that we probably didn't write it optimally. The divide is not between community and academic centers. The divide is with those centers committed to a total quality improvement approach, which is critical. And I think that's where the emphasis should be. Professional societies should be developing the guidelines for optimal screening. Thank you.
Next is Amy Copeland from the Lung Cancer Alliance.
Good morning. I'm Amy Copeland, Director of Medical Outreach for Lung Cancer Alliance, and in that capacity I manage our Screening Centers of Excellence program. I have no financial disclosures. I just wanted to share some thoughts from community cancer centers with whom we work who would be affected by this decision. From a center we work with in Grand Rapids, Michigan, We are a community hospital with the nearest academic institution hundreds of miles away. We have screened over 300 patients, with 6 being diagnosed with lung cancer. If screenings were limited to academic institutions, the majority of our population in West Michigan would not receive this life-saving screening. From a center in Spartanburg, South Carolina, of 50 people screened, 1 was diagnosed with stage 1 lung cancer, resolved with surgery. He was rural and would not have traveled any more than he was already traveling. The closest academic centers are about 4 hours away. The lower socioeconomic status areas we serve are unable to drive those distances. Thank you.
Thank you. Thank you. Next is Gabrielle Guerrier, if I said that correct. And if you are representing an organization, just tell us if the organization has any financial conflicts. Thank you.
Sure. We have no financial conflicts. I'm Gabrielle Geyer. I'm with Lung Cancer Alliance as well. And just to add to what my colleague Amy just said, from Odessa, Texas, the closest academic medical center is 360 miles away. The majority of our Medicare population does not have the financial resources to travel this distance for a lung cancer screening. Restricting access to academic medical centers will cause a severe disparity in our population. Thank you.
Okay, thank you very much. We've now heard from all our presenters, and we now have an hour for the panel to ask questions to the presenters. I'll start off with a question. I want to invite all of the presenters, while we're getting organized, to come sit up here in the first row. And I would suggest people just signal me, and I'll just write names down. And I think, as we do have quite a number of presenters, if there's someone in particular you want to address your question, you should let that be known. And so I'm going to address my question, I think in particular to Dr. Pinsky, because we're talking obviously a lot about the National Lung Screening Trial, which was clearly a very well-done trial, high-quality randomized clinical trial. My question has to do with the choice of using chest X-ray in the control, because it clearly, we know that chest X-ray is not effective in lung cancer screening. The U.S. Preventive Services Task Force looked at that a number of years ago. And my concern is that it's not really a no screening arm, so that you have the same sort of harms from looking at a chest X-ray when you're doing a comparison to CT. There's nodules seen, there's additional testing, a lot of the harms that we're trying to balance the advantage of screening versus no screening, but both of the arms really were screening, and so we're really just looking at 2 different kinds of screening and not screening versus no screening. And I'm just curious if you'd comment on, I know in the paper it says it's because that was being studied in the PLCO trial, but I'm just concerned that we're not really looking at screening versus no screening. Yes, please, Jim.
Yeah, when NLST was started in 2002, results of the PLCO trial, which was comparing chest X-ray versus no screening, were not available yet. So we figured that the 2 trials combined would give an answer of low-dose CT essentially versus usual care or no screening. So that's sort of how that came to be. And then when the PLCO results came out just about the same time as the NLST results, and that showed essentially no difference between chest X-ray and usual care screening. So in that sense, we figured that the mortality rate in the NLST chest X-ray arm would be essentially a surrogate for what mortality would have been with no screening. So that's sort of how that came about. Some of the other trials in Europe, I think, do use an actual no screening arm.
Right, and those trials showed no
Right, but
benefit.
they were very small and underpowered, so.
Okay, well, maybe we'll talk more about harms later on. Dr. Sidrakian?
I wanted to start with the probably most crucial evidence here. It's really estimate of the effect. So we have heard about 20% reduction in mortality, and we heard also that it moved to 16% reduction in mortality as you recalculated the estimates at the end of the follow-up time period. So the question is for Dr. Pinsky and Dr. Bach, in fact. then when you've done some sensitivity analysis, you presented the data on older patients, relatively older, 65 group, the estimates look like 0.87 for the hazard ratio. And we also heard from Dr. Back and many people here today that, in fact, with older age, you have higher chance of cancer, and potentially the benefit should be higher. So we're not seeing that in your estimates. Can you comment about this evidence? Why is it moving towards 1 rather than is getting stronger estimate of the effect in over 65 population?
Well, in terms of NLST, there's 2 ways of really looking at the benefit. One is the relative risk or the percentage mortality reduction, and that was either 0.80 or the 0.84. And when we did that stratified by age, we did find, based on the overall 0.84, that it was 0.87 for the 65 plus and 0.82. But that difference was not close to being statistically significant, and this trial was not powered really for an interaction analysis. So even though the point estimates were different, we don't really think that's evidence that the percentage mortality reduction is necessarily different in the older age group. But besides a percentage reduction, the other way of looking at a benefit is by a number needed to screen. And a number needed to screen takes into account also the underlying mortality rate in the population. So if they have a similar percent mortality reduction, but the older age group has a higher lung cancer mortality rate, the number needed to screen is going to be lower. And the number needed to screen was about 245 in the 65 plus and 360 in the less than 65. So by the metric of number needed to screen, it was more effective in the older age group. One other point is the number needed to screen, again, is the number needed to screen, in this case, the 3 screens to prevent 1 cancer death, but it does not take into account number of life years saved. So in that sense, it might be a little biased in terms of the older age group, because for each life saved, you're saving less years of life than if you save the life of a younger person. So that's also something.
Dr. Beck, you want to comment?
I just want to say, for the reporter, that was Dr. Paul Pinsky, and when people are commenting, please give your name first so the reporter knows who's talking.
Okay, Peter Bach. No, so I basically agree with Paul. I think there's several moving parts here. One is, as Paul noted, that the subgroup analysis by age was sort of unplanned and underpowered, and I don't think there's stark evidence that we see an age difference. Relative risk seems fairly homogeneous. In terms of the number needed to screen, it's driven by the baseline risk of death from lung cancer largely, and so we would expect as you go into more advanced stages to see around the efficacy endpoint improvement. Paul is right. You have to be a cold-hearted economist to look at this way, but nevertheless, the life expectancy prolongation for each averted death is reduced as people get older. So in terms of the net benefit, the intersection between number needed to screen and life expectancy prolongation is one that is tricky. And as I showed earlier, there's this other issue. The 60-day mortality rate following surgery in the NLST was 1%. That's lower than we see in any other observational study, and it was in a young population. In the real world, as age rises, risk rises, and that mitigates against benefit in an important way.
Thank you.
Dr. Bach, while you're there, and if you could bring up slide 29 from Dr. Peter Bach's presentation. But I'll state, because from some of the presenters, you might get the impression that lung cancer screening is going to prevent lung cancer deaths. But when I read the data, that's not really what I read. I read that the absolute risk reduction was 0.33%. I mean, obviously, people still died of lung cancer in the screened group. Some people were saved in the non-screening group. It was and then we're talking about the odds. And so what I wanted to ask was in your decision tool slide, which I think is very helpful for people to actually understand, because I think everyone thinks, yes, if I do get the CT, I won't die from lung cancer, but clearly we heard 332 people would have to be screened, and one person with one lung cancer death would be prevented, assuming the assumptions of the National Lung Screening Trial. The decision tool on that slide 29 said that there were 3 deaths that were prevented in the group that was screened compared to the non-screened group, to the chest x-ray screen group, but that 3 people developed a major complication from the invasive procedure. So it seemed that there was the same number of people getting a major complication from screening, and of course that was with the the sort of lower incidence of follow-up and lower mortality as there was. And I guess that was sort of, was I reading that slide correctly? Because it,
yes,
the actual numbers.
So let me explain the slide. It's not the one that's shown there, but I can describe the slide you showed.
It says 29 of 33.
Yeah, I have no
online.
idea which number it is, unfortunately. But it showed on the left the VA decision tool, which was Rita's describing, the number of deaths from lung cancer, absence screening, and then the suite of events that could occur. This one.
That was the one with all
I hope everyone got
the one
that.
with the colors that you just had.
Yes. So, and I think Rita's looking at the left-hand slide. This is a VA decision tool. It's anchored to the NLST primary results, so it's not tailored to the individual. But this is what you're looking at. And if you will, this shows the sort of balancing of harms and potential benefits of people who are screened. It is always the case with screening that the vast majority of people face a risk of harm, while a very small percentage face a probability of benefit. But the benefits, in the case of this, averted death and things like that, substantially outweigh each of the individual harms. How the calculus works out as the harms mount and the risk falls is a tricky issue, certainly above my pay grade. But the issue on this card that's displayed nicely is that there are harms that are meaningful and there are prevented deaths. It would be a misrepresentation, of course, to tell people that they will not die of lung cancer if they're screened, but the relative risk reduction of 20% seems fairly robust. This, by the way, is why I think it's important, and every single published guideline notes, that individualized decision-making driven by the kind of information on this slide, and even better, tailored to the person's individual level of risk. And as I said, our pedestrian attempt of doing that is in the lower right. That sort of information really should help individuals decide if screening will have future trade-offs for them that they find preferable or not.
Thank you. Dr. Hyatt and then Dr. Grant. And just name the slide that you want brought up.
Yes, this is for Dr. Henschke, and it was a slide that was not projected. Slide 15 in that presentation showed data from a publication around those who had a much more significant smoking cessation experience. It's slide 15 in your presentation. And for those in a CT program, CT screening program. Thank you. That is the correct slide.
Yes.
And I was curious whether you or others might know whether this, in fact, was the situation in the NLST, and if so, what contribution does the smoking cessation make toward improved mortality?
Thank you for your question. This is Claudia Henschke. This is data from LCAP, the initial screening cohort of 1,000 people, 16 older, and it shows, and it's performed by Dr. David Burns, who wrote part of the Surgeon General's report, and it shows that over time, going out to 5 years, that people continue to stop smoking, so that screening does not encourage them to smoke. There may be 1 or 2 that do, but overall, you see that they go down, that the smoking goes down. Now, what was the second part of your?
So I guess my question, because did this same thing occur in the NLST, and was there a difference in smoking cessation between the chest x-ray group and the CT group?
Okay, I'm not an investigator in the NLST,
so Bill, someone else in
someone. But this was without even having any smoking cessation program in place, because this was our early studies before we started putting smoking cessation in.
Yeah, and Dr. Pinsky, if you can answer that, I guess where I'm really going with this is, if there's a difference, did it change the mortality?
Well, we did look at smoking cessation in the NLST, and this is data from what we call the LSS component, which was about 2/3 of NLST. So if you take at baseline the current smokers, and then we asked them every year if they were continuing to smoke. And the quit rate in the CT arm, if you had a positive baseline screen, the quit rate was about 11%, meaning that you, on all subsequent yearly surveys, you said you did not smoke currently. And for a negative screen, it was about 5%. So it's pretty low rates of quitting, but a little higher in the, with a positive screen. And the chest x-ray arm was actually almost identical. So you also had 11% quitting with a positive screen and about 5% quitting with a negative screen.
Dr. Grant, and then Dr. Gould, and then Dr. Ma.
I just wanted to follow up on the matter of effect size. Something I was looking for in in all that I read, but couldn't find. And maybe I'm not sure who can answer, Dr. Pinsky, maybe Mr. Pyerson or whoever. But if you were to take an average 70-year-old in the NLST, if lung cancer was detected, how many quality-adjusted life years would be added? And what's the uncertainty around that for that individual? And let's just take the entire screen entire screen sample, say, of 70-year-olds. How many expected quality-adjusted life years are added?
This is Bruce Pyence, and the answers, which I don't have with me, is in a publication in PLOS of 2013, where we applied quality-adjusted life years to screening or non-screening. So that's the source.
Right, I read that, but that didn't address the question of the Medicare, the elderly population. So that that addressed the 55 to 64-ish?
50 to 64.
Yeah, so that was a different sample. So
the reference and speaking as an actuary to give some approximations, if you obviously for the Medicare population, the future lifetime is lower, and that's why the dollars per life year saved for the Medicare population, the 20 to 25 is higher than for the commercial population. It's not quite twice as high. So because of the increasing incidence of cancer over age, most of the life years saved that we were getting from the 50 to 64 were from the older age of that. And the other characteristic of the Medicare population is that even now, the impact of baby boomers is significant, that there's a big bolus of people who are 65, 66, 67 because of the baby boomers, and population size falls off dramatically. So that not quite doubling is still relevant there. I believe the science of quality-adjusted life years is perhaps not so precise as other aspects of the modeling, so I'm not sure we have the ability to really fine-tune that for the Medicare population.
Although I don't know of direct evidence that answers that question.
Can you state your name first?
I'm sorry, I'm Mike Jacklich. I'm a thoracic surgeon. I gave the presentation for AATS. Although I don't know of direct evidence that provides that, there is several pieces of indirect evidence. Obviously, the life table analysis from the insurance companies show that everybody's expected to have 10 to 15 years in that age range. It's not until you get up to about age 80 that you drop to 7 years of life expectancy, specifically in Caucasian males. What is interesting in the lung cancer screening trials is that the lung cancers that are detected are really early stage cancers. So the overwhelming majority are stage 1s, but more than that, they're actually smaller than other stage 1s. So if you look at the evolution of survival of stage 1 lung cancer that's been reported at different eras, that was generally about 60% for stage 1 in the 1980s. Then that came up to about 70% in the 1990s, early 2000s. In these trials, it's 88% 10-year survival. As Dr. Wood pointed out, 84% 15-year survival. So these are really much earlier stages. Why? Because there's not the occult nodal disease that's missing the radiographic staging of those patients. So you really are finding earlier cancers, and you really are providing higher cure rates for that patient population.
Dr. Pinsky, did you want to address this question?
Yeah. I think I mentioned in my talk this modeling paper that accompanied the U.S. Preventive Services Task Force recommendations, and they have a table of life years gained per lung cancer death averted. And for screening starting at age 60 and ending at age 80, it was roughly about 10 years. So that would be, if your life was saved by screening, then you'd have 10 additional years.
That was based on their models?
And that was based on the SysNet modeling group, which basically used the NLST data to inform their models.
But NLST didn't go to age 80.
Well,
so
that's why they did modeling to extrapolate.
That's what I was just clarifying. It's based on modeling, not actual data. Okay, Dr. Hyatt? I'm sorry. It's Dr. Gould. We'll get to you next.
Yeah, another question for Dr. Pinsky. You gave us some interesting and reassuring results about heterogeneity of treatment effect by age, but you, if I'm not mistaken, have another paper that came out recently looking at HTE by sex, and there was a suggestion that screening might be less effective in men than in women. I'm wondering if you could share those results with us. And then my second question would be if you could tell us a little bit more about the implications or the downstream outcomes of patients who had incidental findings outside of a nodule or a cancer in the NLST, whether on balance those incidental findings resulted in more harm than help or the other way around.
So for the first question, right, we recently published a paper about the NLST results stratified by age and also gender, as well as some other categories. And we found a borderline significant interaction, and that the effect was, the mortality benefit was actually greater in women than in men, as you say. The relative risk estimate was 0.73 in women and 0.92 in men, and that was a p-value for interaction of 0.08. Now, when we looked at more detailed into the histology distribution and everything, I won't go into details, but there were some indications that maybe it was just a chance finding, that in terms of men having more small cell, and that might have been just a chance finding that made it seem like there was less benefit. So that's still an ongoing area of research, I would say. So there's a possibility that maybe there's some differential benefit by sex. And the second question was about non-lung findings. Yeah, I think it's sort of analogous to the situation with CT colonography, where we don't really know, you see these other things that aren't related to the cancer being screened for, and it could be a double-edged sword in terms of maybe there's some benefit in catching these things early, maybe there's harm in doing this additional workup, maybe there's extra costs involved. So I think the Akron component of the NLST is doing a more rigorous analysis because they collected specific data on the non-lung findings follow-up. So if anyone else has comments on that.
Dr. Pinsky, while you're there, I have another question on the... So you told us 96% of the nodules were not actually cancers that were seen, but a lot of those patients, it seemed to me, if I read your trial, were told to wait some variable amount of time, 3 months, 6 months, a year for repeat imaging. What were they told at the time about their findings, and did they spend that year essentially thinking they might have lung cancer? And
well, I mean, we had a standard positive screen letter that said, you have a positive screen. I think there was language just saying, this doesn't mean you definitely have lung cancer, but it's something that you should work up. And then usually patients in 3 or 4 month period, would get a diagnostic CT or some other follow-up. I mean, we are doing some quality of life, measures to measure the anxiety associated with, having a positive screen. And I think, there's some short-term anxiety and maybe quality of life deficit, but it was fairly short term. But
was quality of life measured in NLST?
I think there were some sub studies. I think more in the Akron component, the 1/3, but they did some more detailed studies, including quality of life, and that may be being ready for publication. I don't know if it's published yet.
Okay, I didn't see it reported, but it looks like Dr. Jacobson wants to tell us something about that.
Part of of what you're looking at has to do with the harmonization, but within the Akron portion of the trial, the initial, when we started, the follow-up was to be 3 months, and the first patient we had who actually had lung cancer, by the time she came back at 3 months, we had changed the follow-up to 6 months. So the inconsistency is not entirely random from what practice is, although in clinical practice, it's not uncommon sometimes to see a recommendation that would be 3 to 6 months. So if you think of it in that kind of way, but as a PI, I had the actual contact with the patient. And at the time, because you're going back to 2002, we had just started learning about what these early lung cancers look like. So it was a very honest thing of not knowing for sure what we were looking at. We are much quicker to jump on early lung cancer now than we were then. Okay. And it was also for our patients who participated in an NLST more comforting and less concerning. The patient I'm describing actually got referred for some pulmonary rehab. And when she came back at 6 months, she told me that she had regained her ability to climb stairs and sit on the floor and play with her grandchildren, which she retained after she had the definitive surgery for her lung cancer.
And I thought you were going to come in on the quality of life data.
The quality of life data was collected in NLST. It was a very extensive set of questionnaires, and patients were contacted in the Akron side on an every 6-month basis to get both their medical experience that was outside the trial and also to assess with standard questionnaires their quality of life and activities of daily living.
Okay, and is that reported somewhere? I haven't seen it.
I think that it will come out. It's probably not immediately available in print yet.
But the trial was completed 5 years ago.
The number of writing groups in that trial is quite large. I'm probably not the best person to speak to the stage of the writing groups, because I have moved over and become involved with COPD gene, and we have an enormous number of writing groups, and 50 years from now, all of these activities will come together to improve the health and decrease the death from lung cancer and the morbidity from other tobacco-associated diseases.
Thank
you. Jim Mulshine. The Linda Humphreys article from the U.S. Preventive Services Task Force dealt with the issues of quality of life, cited 7 publications, the best of which is from the Nelson trial, which is the large European randomized trial, which is still ongoing, but their preliminary results have been published, and the diagnostic workup has been published, and the quality of life pilots have been published. And they, in fact, have very favorable results, very similar, comparable distribution of stage. In fact, it's better than the NLST. They found operative complications and morbidity from the workups they published on, and it's quite modest in their expectation. The quality of life tools that they used showed no significant adverse quality of life impact. They had some trends that they discussed, but overall it was well received. And that trial, in fact, will be published in a relatively short period of time, within 2 years. But it tracks very closely with the results we've been talking about today.
Okay, let's move on. So the next was Dr. Curtis Mock, and then I see Dr. Howard.
I have actually 4 questions, but I'll just take them 1 or 2 at a time. I'd like to start first with the whole issue of access. I heard access mentioned a couple of times today, but I'm a bit confused. As I looked at a map earlier in the presentation, it seemed to be there were certain areas of the country where there was a marked density of these screening centers. Could you just help me understand, if we use, for example, the number of centers in Georgia versus the number of centers in Mississippi? And we looked at the incidence actually is higher in Mississippi than Georgia, if I looked at the map correctly. So please help me understand, as we look at this globally for Medicare beneficiaries across the country, how do we justify making this available for a beneficiary regardless of where they live?
Lori Fenton Ambrose with Lung Cancer Alliance, and thank you. Access, of course, is one of the key considerations, but it's also how we build public health infrastructure at this moment in time to meet that demand and need. And what we've been attempting to do is work from the get-go with community centers, hospital centers around the country who are saying, we need to do this, help us figure it out, what types of standards should we be following, and trying to ensure that we are doing everything we can to support capacity wherever it could be. These states, Georgia particularly, has shown extraordinary forward thinking. They have been evaluating this years ago and trying to build the infrastructure to help meet the demand. Mississippi will get there, and in fact, I believe we have a center of excellence that will soon come online. But it does take time, and it is a process within these centers to gather their respective teams, get the buy-in, understand the process, build their infrastructure, and then roll it out. But that's what we've been trying to do, is work with them as quickly, as responsibly as possible, and go proactively to these areas where there is high incidence across the country and see where we could start this now. Not wait, but start it now. So,
what other criteria can you share with us besides interest at the local site?
well, by the framework is in essence a blueprint. We've been working on 8 key elements that we hope to have as a part of every screening center of excellence. So we did research on where comprehensive cancer centers are located, where are NCCN-related centers, what were the NLST sites, Akron sites, and began to proactively reach out and build from the get-go a mindset, a culture of a consciousness around what really is responsible screening and how can we move this forward as rapidly as possible, and to also work in collaboration with the Community Cancer Association for Community Cancer Centers, and all other kinds of state entities to say, this is here, it's a proven benefit, how can we move as uniformly and as responsibly forward now? Let's get together, let's figure this out, and get to work, and then use you as a mentor for other community centers, other hospitals, to share lessons learned and continue to push this out in that kind of a responsible way.
Yeah, thank you.
Dr. David Howard.
So my question refers or pertains to screening in the over age 75 population. I believe modeling studies for colonoscopy show that there's a large benefit for the first screen, but the benefit declines rapidly with each successive screen. If and when lung cancer screening diffuses into widespread practice, you'll have people who are arriving at age 75 having been screened for lung cancer 10, possibly 20 times previously, all with negative results. So my question is, for people who reach that point, who are age 75 or 76, having had a long history of negative lung cancer screens, are the benefits and harms of lung cancer screening that we observed in the trials, would they grow more or less favorable for that type of population?
David, so first,
Dr. Bach.
Sorry, Peter Bach. Sorry. We don't have empiric data, right? And that's what I pointed out. You can speculate about directionality, and it could go either way. There's basic questions like the frequency, whether or not there's risk groups that should be screened either more frequently or less frequently. One of the intriguing things, and if you want to read the tea leaves in the data in the NLST, I showed the graph from the ARC technical report. And what I noted, that black line, was that the relative risk of death from lung cancer actually went almost immediately to 1.2 in chest X-ray versus CT. In fact, you can see we have the primary data now, and you can see that at 6 months. And then it sort of held steady, which suggests that a lot of this speculation that long-term kind of pocketed up benefits are not as important, perhaps, as near-term benefits. In other words, lung cancer screening may be more like a vaccine that only works the year you give it than it does something delayed, a vaccine, for example, that holds for 10 years. I don't want to overread the data. I am speculating somewhat wildly, but that's what the data is telling us right now.
We've been screening people
Please
for
state your
a
name.
long period, Claudia Hengschke. We've been screening people for a long period of time. Each annual round, different from that first round, provides about the same frequency of new cancers. And as the age increases, there will be more cancers. So it's different from colonoscopy. in that sense. So each round in each year provides an additional benefit, and as the population ages, there are more cancers being detected with the additional benefit that was shown in the NLST.
Dr. Hyatt?
So this question is for Dr. Frank, and I don't know if MIDA has data on this, but I was curious whether the proportion of existing installed CT scanners that actually meet the most current low-dose capability is a known piece of data, and are they relatively evenly distributed geographically, the optimal equipment? I'm thinking that with the economic downturn and deferred capital investment that we may not really have very evenly spaced access to the best equipment.
I might invite Dr. McNitt to answer this question as well. Certainly the adoption of more modern equipment is not universal and homogeneous, and it tends to be in academic centers and then ultimately in community centers. But the fact of the matter is that the data that I showed you from the ILCAP trial already document half the level of exposure per scan than was in the NLST study. And those do include a significant proportion of community hospitals. I think there is a small proportion of hospitals in the outlying districts that perhaps have what might be considered outdated CTs, and so there is a significant role for ACR in their dose registry to capture this information. The dose registry has resulted in a narrowing in the variation across sites and the dose administered and an overall reduction. So I think expansion of that dose registry to all those hospitals will help to get a more quantitative answer to your question. But I think it's a small issue that will resolve quite naturally over the next year or two.
So let me ask it a little bit more clearly then. There are a certain number of CT scanners in the country. What % currently have the dose reduction software and the capability of achieving the lowest dose that the newer scanners have?
Yeah, I don't have a specific number. I think that the majority of them, certainly the large majority of them, do have that software and that capability for the doses that you see here. Whether that's 70% or 80% or 90%, I can't say, but MIDA could take as an action to provide that information if it became crucial to CMS and deliberations.
Along that line, it's Dr. Redberg, some of our comments noted that there's evidence that low-dose techniques are not routinely used for lung cancer screening, and that at the same institution, a patient one day might get a dose of 1.5 millisieverts, and another day at the same institution get 15 millisieverts for lung cancer screening, and that a survey of radiologists, 834 radiologists published by Eisenberg, said half of them did not know the two current settings used for diagnostic and follow-up chest CT examinations at their facilities. Obviously, the NLST used radiologists that were trained and accredited, but it doesn't seem that that is a standard we can now rely on across the country.
Sure. Now, NLST, of course, was conducted, I won't say ancient history, but a few years ago, and things have moved on from there, both in terms of the technology, dissemination of that technology, and, for example, the protocols to which the AAPM referred. And so with the advent of coverage, there will be quality standards and so on that will be disseminated and dramatically enhance the likelihood that everyone is using the AAPM recommended protocol, everyone participating in the ACR dose registry and so on, so that you can be assured that people are not being unnecessarily overdosed.
So you're saying that new quality standards would need to be developed, but there are none currently in place?
They are developed. It's a matter of disseminating them. You heard from Dr. McNitt what the AAPM are doing. They have protocols already and have refined those. You've heard from Ella Casaroni about ACR's standards and accreditation and training and so on, and those are in place and being rolled out, yes.
Dr. McNitt-Gray.
Mike McNitt-Gray from UCLA. I would suggest that outside of the NLST, there has not been in clinical practice a consensus on what is a screening exam. So the responses that you would get from radiologists or from places saying their techniques were all over the place, I think reflects more not a clear understanding of what is or isn't a screening program than it does the doses. I think that in the context of the American College of the NLST, the doses were pretty tight. I think within other screening programs that I'm aware of, the doses are pretty tight. I think these activities of the ACR and the APM will also help narrow the range of doses. We won't see 15 millisieverts for chest screening CTs. We won't see that. We may see 1.5 millisieverts.
How do you know you don't see that?
We won't. 1.5 millisieverts and below. We'll most likely see the vast majority of scans performed well below 1.5 millisievert.
Maybe briefly, because there are about
so Ella
6 more
Cancerini
people.
for about the ACR accredits more CT scanners in the United States than any other organization. We accredit facilities with over 3,000 facilities with CT scanners. We have developed and ACR approved guidelines for low radiation exposure for low dose CT scans. These set the technical parameters that we expect radiologists to follow, and we're embedding them in our CT accreditation program. So we do expect these will be easily accessible and routinely practiced across the country. As a secondary note, as a thoracic radiologist at our institution at the University of Michigan, we load a large number of outside exams into our PAC system every month. Over 10,000 exams from outside facilities are loaded into our system, and we reinterpret many CT scans that come from a diversity of practices. Very few of those are done with anything but helical scans today, and this reflects practices from across the Midwest and across the country.
Thank you. And I did understand that the guidelines are in place. My concern is more that the implementation is not always the ideal. But I'd like to move on. Dr. Milkus is next, then Dr. Hyatt, Dr. Grant, Dr. Sidrakian.
Yes, this question may be for Dr. Pinsky or Dr. Bach. There's already been questions raised about the evidence based on gender and age differences and the implications of such. Can either of you speak to ethnic minority groups, seeing that they're an emerging majority for which this will have implications for?
I think the percent of ethnic minorities was fairly low in NLST, but it was representative of the NLST eligible population in the U.S. But the groups were 5 or 10% of the total, so it's very hard to make any, unless something was way different, it'd be very hard to make any conclusions about whether effectiveness was different in those populations. But again, that's a good thing to be looking at if we go with a registry or follow-up of practice.
Peter Bach, thanks for the question. It's difficult to extrapolate to any group, but in the case, at least in the context of African Americans versus Caucasians, which is the comparison that's best studied, and I've been lucky enough to work in that area, there's little evidence that there are underlying biologic or genetic differences or other pathophysiologic differences that would affect whether or not CT screening works or not in those groups. Other groups, I think, are less well studied.
Okay. Dr. Stephen Wolf, and then Dr. Doria Rose, and then we'll go.
Thank you. Is this on? I guess so. I have a whole bunch of questions, but in the interest of time, we'll just limit it to two. On the issue of harms, we've talked a lot about benefits. I'm a little puzzled, and I'm not sure who to direct the question to, but there's been a thread in the comments that have been made dismissing or minimizing the significance of the inaccuracy of this test. Its positive predictive value, depending on what numbers we look at, is 5% or lower in the NLST, maybe a little bit higher. That's terribly low for a cancer screening test. It means that 95% of people who have an abnormal result don't have cancer. So although we do see the 20% reduction in mortality benefit, if I read the NLST data correctly, in 26,000 people that were screened over the 3 years, 83 deaths were averted. That's the 20% reduction. But that means 26,000 minus 83 went through the screening experience and didn't have their deaths averted. So we have a responsibility to think about potential harms there. The two comments that were made that I want to understand better is, number one, I think it was Dr. Wood who said that the assertion from the American Academy of Family Physicians that a long-term screening program over time would lead to increasing proportions of the population having received a false positive result was incorrect. Seems to go against a basic principle of epidemiology. I think that's a misunderstanding. I think the point Dr. Wood was trying to make was that over time the positive predictive value improves. That may be true, but it's also true, as the American Academy of Family Physicians said, as is true for most cancer screening programs, that over time the screened population would eventually have a larger and larger percentage of the population that had received a false positive result. The other question for Dr. Wender was the claim that the assertions about the rate of overdiagnosis are overstated. I sense here that the term overdiagnosis is being used in slightly different ways. The technical use that I think Dr. Wender is referring to is the overdiagnosis of lung cancers that ultimately pose no clinical significance to the patient. The term is also used more generally in the medical community to refer to the diagnosis of conditions other than lung cancer, incidental findings, for example, that pose no clinical threat to the patient. But my reading of the data is actually we don't know what the overdiagnosis rate is for either of those things, and I'm wondering whether the intellectually honest answer is to say that's unknown rather than to say it's almost certainly small. So two questions: why Dr. Wood was challenging what seemed like a pretty basic assertion, and secondly, isn't it true we don't really know what the overdiagnosis rate is?
So this is Doug Woods, that you directed that directly to me, and my challenge to Dr. Campos is a misunderstanding of what's determined a false positive, because over time, as shown by Dr. Pinsky in his presentation, a second scan that shows stability shows that the earlier positive becomes a negative. So over time, actually, the false positives decrease rather than increase in lung cancer screening, and that seems to be misunderstood by Dr. Campos and yourself. I recognize the incongruity of that, but the point is that the accuracy increases over time because of the comparative studies.
If you have
and there were other questions about harms, which there was questions about the mortality being in comparison to 1% versus 4%, but all of the current studies, including from the STS National Database, has a surgical mortality for lung cancer resections of around 1% now, so it's not 4% as otherwise quoted.
It's a basic principle of Bayes' theorem. If you do a chemistry panel and repeat it on yourself multiple times, you will increasingly get more false positive results. This is a test with roughly 75% specificity. If you keep repeating it for statistical reasons, you will increasingly produce false positive results.
Rich Wender, let me quickly, and although I'll mainly address the overdiagnosis, quickly address the question of the false positives. I think it's very careful in all cancer screening that we look at how false positives are resolved. A false positive that is resolved with additional screening is different than an additional one or two additional images, for example, is very different impact on a patient than a false positive that leads to a biopsy that did not show cancer. And we saw a lot of data that we're now able to keep that rate very low. Don't mean to minimize that it's not a false positive. It still is. It was not cancer. The second thing is a technical point in the trial. The definition of if you were positive at the first screen, you were continued to be considered to be a false positive, even if it was just the same nodule that was reported. I'm not sure if every site did that, but most sites would continue to call that a false positive at the 3 screens, even though it was only that one nodule seen on the first screen. So that's just a more technical point. Let me comment on overdiagnosis. First of all, I was just commenting about overdiagnosis of the lung cancer. I was not commenting about incidental findings. And I agree, the true rate of overdiagnosis of lung cancer histological screening is unknown. I think the critical point was made earlier. We are now seeing through screening a stage of lung cancer that frankly was not previously known or seen in large numbers. we are averting
Can we limit
deaths.
our comments to 30 seconds so that we manage to hear from everyone?
My apology. I tried to do 2 questions. So I got 30 per second. The death rates, the death rates that we're averting are much further down the road than we're used to seeing in lung cancer. Thus, you need very long follow-ups to truly measure overdiagnosis between the screened and unscreened group.
Thank you.
Peter Bach, in under 30 seconds. I think you're both right. You're not saying the same thing about incremental false positives. For sure, each time you screen a person, the chance that they will have a newly detected nodule rises. As a proportional matter, the data seem to suggest that that falls over time in sequential screening. On the overdiagnosis issue, there's a couple of moving parts. Paul and I agree on this one. It's probably about 20% in the NLST. That's the incremental lung cancers over in the CT versus chest X-ray. And then with the additional follow-up for catch-up. And that ratio persists. And remember, chest X-rays itself causes overdiagnosis. It's pretty clear from the Mayo data and the Czech data, and that's all masked. So if you compare usual care to CT, overdiagnosis rate would be greater.
Hi, Dan Raz. One piece of information about overdiagnosis. So we know that in terms of natural history of untreated stage 1 lung cancer from the California Cancer Registry, that patients who have biopsy-proven stage 1 lung cancer have about a 6% 5-year survival. And granted, that's a population-based study. It's not a screening study. However, the vast majority of stage 1 lung cancers are still detected incidentally, so they are fairly comparable to screen-detected lung cancers.
Dr. Paul Doria-Rose.
Thanks. This question was for Dr. Pinsky. So we've talked a little bit about subgroup analyses that were done within the NLST, and I wanted to bring up actually the paper that Dr. Bach talked about by Kovalchuk that looked at kind of the benefit according to what your risk was, and there was a heterogeneity of risk even within the high-risk smoking population that was included in the NLST. And one of the things they reported in that paper was that those with a higher number of comorbidities didn't benefit. And I was just curious if you had some comment. I know you've done work as well about the kind of healthy volunteer effect in trials as to how the trial participants would compare to the general population with respect to other comorbidities which may impact the benefit of screening.
Yeah, in that paper, they looked at the quintiles of lung cancer risk and showed, a differential number needed to screen based on the quintiles of lung cancer risk. I'm not aware of the part of their paper that looked at comorbidities. I mean, in general, I would say NLST, especially for that rate of smoking history, was healthier and had fewer comorbidities than the overall NLST eligible population in the U.S. I'm not sure how to quantify that, but I think that would be, a readily accepted statement. Certainly in terms of COPD and history of MI and other things. So how that would play out, I don't know.
Dr. Grant, then Dr. Hyatt, then Dr. Gould. Pardon?
That was my question.
Oh, great. Okay. We'll go to Dr. Hyatt.
Yeah, thank you. This is for Dr. Bach and Dr. Casaroni. I was concerned about the variability in the radiologists' interpretations, rates of the detection, and this was in a relatively controlled environment with training and standards set. And so as you think about, and the American College of Radiology thinks about how to reduce that variability among radiologists, what can we expect as this rolls out into the community?
Yeah, so Peter Bach, I think you're talking about one of Paul's slides, which showed the across radiologist variability. But I don't know where Ella is, but I think Ella's the best one to answer this.
It's right there. So I think as Paul showed, this Ella Casaroni, there was radiologist variability. We published on that at NLST about detection rates and false positives, but we also have to recognize that NLST was performed across a broad geography, and we have not delved into the details of other influences of local practice. Is it the individual? Is it the geography? If you live in the histoplasmosis belt or you live in Arizona area, you'd expect to have a larger number of non-calcified underlying lung nodules at baseline that after 2 years would fall down to negative screens. So it's not clear whether the radiologist variability was necessarily one of skill, because they were all trained, versus one of the underlying population that was being screened and the geographic differences of those individuals.
Dr. Michael Gould?
Yeah, so I have a comment and then a question for Ms. Ambrose. The comment is to kind of clarify the record. So there was a suggestion made before that based on data from Nelson that the participants who underwent screening tolerated it well, had no objection. It's important to note there have been at least 2 studies of qualitative studies of patient distress in people who've been diagnosed with lung nodules. Both were in VA settings, neither were in the context of screening, but both showed that there's considerable distress in as many as 25 to 50% of people who are found to have a lung nodule, and that distress can linger for as long as 2 years, depending on how long follow-up continues until lung cancer is ruled out. One of those papers is by Renda Weiner from Boston University. The other one is from Chris Latour at Oregon Health Sciences. And then my question for Ms. Ambrose, first of all, thank you for your presentation and thank you for the work that your organization is doing. And I think we need to have a frank discussion about generalizability. And to me, there's a very, very clear tension here. On the one hand, we want to make sure that the technology is available to as many people as possible who can benefit from it. On the other hand, we want to make sure that it's done safely, and I think your organization recognizes that. Given what we know about the highly variable quality of health care in diverse settings throughout the United States, would it not be unreasonable, and would your organization support a coverage determination that says we need to make sure this is done right, and these are the following conditions that we would attach to make sure that screening is done safely in the right patients who have the right information, can make an informed decision, who get followed up appropriately, and are not exposed to unnecessary harm from a false positive?
Lori Fenton, and thank you so much for that question, because clearly it is a goal that every one of us here shares, and that's how do we take a proven benefit and make sure that it is deployed safely and responsibly. What we were hearing from our patients and consumers was, am I at risk? Should I be screened? Where do I go? And that's what we attempted to address immediately. And the key is whether or not we need to make screening contingent on the collection of more evidence for the USPSTF population. And I believe that we can uniformly say here, with some exceptions, that we can move this forward and that we do have structured reporting systems, we have protocols, we have technological capacities, and we have the desire by healthcare teams to do this. And the key is saying, here are the requirements to do this well and right, are the principles, and allow these community centers within the context of those principles to then deploy it based on what their community's needs are. So yes, that's what the guiding principles are saying, and we're seeing pushed out across the country. But I don't think we have to make screening this population contingent on the collection of more data.
Well, who can how can we be sure that those principles are going to be followed? And with no disrespect intended, is it really up to the Lung Cancer Alliance to determine who's a center of excellence? And would you support CMS having some criteria for who becomes a center of excellence?
I think we could probably all gather and figure that out, as ACR, STS, our organization, among others, has done. And that would be a wonderful opportunity to really go through this in far more detail than perhaps time allows here, to again reinforce what is in place, what is being observed, and how we can work together collectively to embed it properly in public health infrastructure. But I would like to say, please have confidence in the professional societies whose direct responsibility is to set up these screening criteria and protocols to know they're doing it well and right now.
Thank you. We're going to move on. Dr. Sidrakian.
Yeah, we're going to stop these question and answers because of the purpose of the time. We have a few more questions, and we're close to
the
lunch
hour,
time.
and there are several more questions.
10 minutes after.
I just want to reinforce the point that was said earlier. The ACR accredits the majority of outpatient CT scanners in the U.S.
Okay, you
today
did
under
make that
HIPAA,
point. Thank you.
And those criteria are
Thank
part
you.
of that, and CMS recognizes that already today.
Thank you. I really want to go back to the presented evidence about the strength of the data and particularly the lung cancer mortality, all-cause mortality issues that were brought up from the beginning, and why we suddenly put the all-cause mortality in this situation into back burner. Is there any reason that we wouldn't consider all-cause mortality? Can someone present a data that would mean that patients value more from dying other causes than cancer? Is there any data that you'd like to comment on?
The standard, in the context of a cancer treatment trial, all-cause mortality is the standard endpoint. But in a screening trial, the standard endpoint is cause-specific mortality just because the numbers just don't make sense when you look at all-cause mortality, because most cancers are going to be a very small percent of all-cause mortality. So the standard in screening trials is cause-specific mortality. Now, the NLST, I think, is the only cancer screening trial that I know of that has shown a significant overall mortality rate, and that's because it's a very high-risk population, and lung cancer is high risk.
My point is, do we have to stick to the mainstream interpretation of this in this situation? Also, as you presented the data on strength of the evidence, the overall data from around the world was certainly moving the strength towards the null. We were getting a weaker evidence if we were to look all of the publications for many of these trials. So my point is the level of confidence, is that in any way influencing you? Peter, you want to talk about in 2008 you had a publication saying with screening we're not necessarily getting those cancers that can be prevented. Did you change your opinion based on this large trial?
Peter Bach, yes, I changed my opinion on that. The NLST clearly showed that you saw a reduction in advanced stage disease amongst CT screened individuals. It's the highest quality trial. We have these other RCTs. They're in all of these reports, all these slide decks. They are weak evidence at best. They're underpowered. They're in insufficient duration. There's probably contamination as well. But there are the data. So the issue, just to cut these things with the right razor, the NLST showed a reduction in death from lung cancer. It showed a reduction in death from all-cause mortality because so many patients were at risk of dying of lung cancer. When you subtract out the lung cancer deaths, there was no longer a reduction in causes of deaths from other causes that was statistically significant. But the important finding here is that there was not an attendant harm from screening causing deaths from other causes. So instead of a patient, for example, dying of lung cancer, they die of a biopsy for the lung cancer. They die of a heart attack because they're worked up for lung cancer.
Thank you.
So that was the issue.
Okay, but I would just, as a clinician seeing patients, if I was going to do shared decision making, I think honestly, the decision tool we saw was lung cancer mortality, but I think it's fair to say it's patients care, are they going to live longer? They don't care, are they going to, what are they going to die of? And so you would have to say, looking at all the data we saw, the all-cause mortality relative risk was right on the one line. You would say you're going to have tests, you're going to have screening, you may be worried about lung cancer for some indeterminate period of time, but when you're going to die is not going to be extended.
Yeah, I don't think I agree with that interpretation of the data. There's a sample size issue that's really important there. So I think if we read this and extrapolate to the population as a whole, we would not expect a reduction or even an equal life expectancy. We would expect a small prolongation because you would.
So you didn't see the all-cause mortality at 1?
Yes, of course I did. But I'm telling you what I think the data from the NLST says to us, which is that the all-cause mortality would either be reduced or be shaded towards a reduction in lung cancer death.
Okay, we should move on. Dr. Fendrick.
Thanks. Am I keeping us from lunch? So I have a concern that I want to share mostly with my panelists, but since I've been accused in the past of not sharing my concerns with the presenters when they're here, I'm going to present them now. So I've spent my career basically trying to implement very targeted, clinically nuanced benefit designs. And I'll tell you that if you even think about something much more simple than CT screening for lung cancer, colon cancer screening, you don't do it before 50 unless there's a family history. 50 to 75, okay. 75 to 85, not so okay. 85, not very good and harmful. We're still spending $1 billion in CMS screening 85-year-olds. And this raises my concern about the fact that this is a very nuanced population that we're talking about a coverage decision. And if you look at the U.S. Preventive Services Task Force, for instance, to get under the task force, a free screening for diabetes, you have to have hypertension, which we don't do very well. And to screen for abdominal aortic aneurysms, you have to smoke, which we don't even know how to do. And just about every commercial health plan I'm working with has no idea how to either provide free AAA screening for smokers or not, and most of them either give it to everyone or no one, or they're still confused. So I don't want to talk about venue. I don't want to talk about the data. What I want to talk about here is these are very strict, nuanced recommendations, of which a lot of people are arguing even in those populations whether there's net value. I want to hear, if anyone, or we'll talk about this later, how confident are we that we will be able to implement a coverage decision around these clinical parameters that we know, at least in any history, we've never been able to do this before. I don't want this to be lung volume reduction surgery. I don't want this to be lap chole. I do not want this to be PSA. And I would like, if anyone could tell me that they have said that none of these people that are older or sicker or all these other folks that are come flying in, and we're going to not only spend millions or billions of dollars, but harm people, I have reservations.
Okay. Well, now we get to go to lunch.
I just want one quick thing in response to Peter.
Identify yourself.
Mark Grant, I'm sorry. I wouldn't be so quick to discount, I think there are 7 European trials underway that intend to, or I think have accrued close to 30,000 patients. To dismiss them, I think in the perspective of synthesizing evidence, clearly the NLST is, is the gargantuan piece there, and it's an unbiased trial from the internal validities perspective. But I think it behooves us to acknowledge those results and also to anticipate that further results will be coming in rather soon. Patients were accrued differently in many of those trials. The trials have other aspects that are important. For example, some of the psychosocial questionnaires that were included. And so I'm a little bit uncomfortable just saying, oh, we're just going to look at the NLST and just say make the entire decision or evidence assessment based on that.
Quickly, Jim Melshon, I've been involved in the development of a lot of those trials. The Nelson is clearly the best of that breed. The Nelson has been published already in this preliminary diagnostic workup, New England Journal. Robin Clapper was the first author. The diagnostic sensitivity of that analysis was reported as 95%. The diagnostic specificity was reported as 99%. The outcomes were excellent. The stage distribution is very favorable. I agree with you. I think it's going to be very supportive.
Okay, thank you. We are now at 12:19. So we will, we're a little bit late, so we will come back from lunch at 1:15. So we have essentially an hour for lunch.